I'm really sorry that I will pronounce everybody names, but but I can pronounce every name correctly. He will present today functional and anatomical outcome of inside our technique for cholestetoma surgery. Please, Mr. Chandra.
Good morning, everybody. Thank you so much for giving me opportunity to present my work. So I am associate professor in Datta Meke Institute of Medical Science, Wardha, India, and we have done lots of research work there. So one of the my work I am presenting here, the functional and anatomical outcome of inside out technique for the cholestoma surgery. Introduction. The objective of a study was to study the efficacy of inside out approach is completely eradicating the cholestoma from the middle ear and the mastoid, preservation of the hearing and quality of life, the post mastectomy with regards to recurrent discharge and wax and granuloma. An inside-out approach following the disease is the direction of its spread. This helps in the limiting the extent of cavity, the ability to stop the operation as required. Here we study the inside-out approach to modify radical mastectomy, its function and anatomical advantage. In the material methods, patient undergoing surgery for cholestoma, we have taken 100 patients. That is the non-randomized prospective study and observational study. And duration of study was 3 years. And in the inclusion criteria, we have taken any age patient which have presence of cholestoma. Done this surgery the operative technique. This is the mastectomy. Mastectomy was under the local and general anesthesia. All cases that were done under the local anesthesia were sedated by the using injection, pethidine 50 milligram, and injection promethazine 25 milligram given intramuscularly. Electrocardiogram or oxygen saturation were monitored during the injection of local anesthetic agents and throughout the operation. Local anesthetics consisting the 2% lubricant with the 1:1.5 apostolic group or paralleling the linear temporalis. This permit layer closure of the non
horizontal cut. Visualize this tympanic membrane. Make sure that canal wall is more or less lifted up to the anterior canal wall. And at 12 o'clock, we take a vertical incision outwards. This is nothing but the deeper part of an endural incision. But what it does is takes your flap away and gives you much more space in the externality canal. As you realize here, you don't require canal wall retractors, just two 2x2 retractors are enough to do a mastorectomy. As you see that, that's the tympanic membrane, that's the attic defect. And I've taken a short posterior canal wall flap. I generally prefer to take that because you don't want it to be at risk in your drilling. Anteriorly, as I said, take a more anterior flap to be able to lift up the pocket completely. And the drilling began. As you see, the drilling, in spite of this being a nice wide external canal, is still begun. That's the spine of Henle being taken out. It's still begun laterally. You do not want to work in a hole. You want to make the external canal nice and wide before you approach the disease. Usually, we put a large piece of silastic to protect that skin from getting pushed into the drill. For some reason, we haven't done in this patient. Again, as you see, you know the level of the ossicles, you know the level of the facial nerve, and therefore surgery becomes simple and you're able to approach with confidence. As you see, my drill is touching the bone only when it goes from right to left. When it's coming from left to right, it gets lifted up. And that's why every piece of drilling cuts bone. You must have nice, sharp cutting drills, which will give you better control. So you don't have to apply pressure, which is most important. Canal now is nicely widened up, and we go towards the attic defect. Then in this patient, it appears that the ossicular block of incus malleus seems to be intact. Once we go closer to the ossicles, we take a diamond drill. Closer to the tegmen there. So now you see that the pocket seems to be fully exteriorized. As you realize, it's doing this from inside up.
Sorry. A tremendous advantage for this patient, not having to separate this from behind. Yes, mucus, non-process, and a pocket in that area, which we need to lift. Always remove the epithelium along the stapedius, because that's the only support that you have for the stapes. So along the direction of the stapedius from back to front. The pocket is quite nicely lifted.
And as you realize that under the pocket is a nicely well ventilated master. Therefore, there is no fear of this pocket actually deepening now. Whatever damage has taken place in the past has taken place. But today, it's a nicely ventilated middle ear under the pocket. Once the pocket is nicely lifted, you can see that the middle ear is well ventilated.
Hi.
This pocket is fully lifted now. There is, and it's quite a smooth cavity superiorly. Just preparing a bed so that when the graft is placed, epithelium covers it nicely. That's the anterior attic. Also, as you see, nicely ventilated. All this is possible because our canal was anyway destroyed and wide, the attic was open. And to do the same thing from a posterior approach, just because somebody is trained like that, is very difficult. I'm showing you these cases particularly because they demonstrate the real advantage of an inside out. Once you use it on regular basis, you'll discover many advantages on every case, but these are really cases where it will really make a difference if you are doing inside out compared to opening the mastoid from behind. As you see now, the pocket is completely lifted from the incus and the stapes. And the ossicular seems to be rather intact. Though incus is quite eroded and thin, but it's intact. And an intact ossicular chain like this, I would not like to disrupt because it might, fall down again. Because the hearing is good, one thing that is certain is in cholesteatoma, you will maintain that hearing. So once the pocket is lifted completely, the only thing to be done here is to reconstruct the attic and maybe put a piece of cartilage in that area over the incus and the stapes, just in case it would
Merci.
Merci. Hein.
Once the post-oral incision has been pocketed and destroyed, so even if suppose the incus was to get destroyed, the cartilage would remain in contact with the stapes and maintain the hearing to that level. Once the cholesteatoma is completely removed, you only need to graft the defect and reconstruct the posterior canal wall. That's the temporalis fascia. The cartilage has been taken out, measured, and kept. So the graft is put under the tympanic membrane, the middle ear. A piece of tragal cartilage to close the attic defect. Another piece of cartilage to go onto the below that piece of cartilage over the long process of the incus and in the posterior part of the mesoaortic. We fill up the middle external canal with gel foam and close the ear as usual.
In the procedure, the posterior tympanotomy, the posterior canal skin was elevated after the posterior incision, separating the underlying bone and the canal entered, making the incision along with the posterior canal wall skin, and standard vascular strip incision was made, and temporometer flap was elevated and designed. Then we do the epitympanotomy. The bony meatus was enlarged within the 3 to 4 mm cutting bar to remove the from bone from the posterior and superior wall of the external meatus at the isthmus, including the Henle spine, so the separating the overhang from the outer bed and straining the meatus before removing the outer epitympanic wall. The attic opening was then enlarged with the 2 mm bar and a small curate working from the within the outward to expose the cholesteatoma fully, and when necessary into the flush with the tegmen superiorly. Anteriorly, bone removal was extended either beyond the limit of cholesteatoma or flush with the anterior epitympanic wall, while the drilling great care was taken not to make contact with the intact ossicular chain or fear of including greater hearing loss. Then we do the epitympanomasterectomy. After the 4 mm cutting bar was used to circulating pattern of the enlarging the meatus till the whole cholesteatoma is uncapped. At the epitympanum is already open and incus is easily made out. Bone of the posterior wall can be lowered with the uncapping of the level of the plane, thus protecting the facial canal. The bar was used within the outward away from the facial canal, along with the assessing the depth. If the body of the incus was absent, position of the facial canal was ascertained either by lifting the epitympanic portion of the cholesteatoma to set lying within the canal or by the seeing stepping remnant. After knowing the position and posterior canal was lowered to the suitable depth. Then removal of the disease. Entire cholesteatoma matrix was exteriorized. Cholesteatoma going into the institution tube can be removed successfully without restoring a radical mastectomy, but occasionally etiositis or diffuse disease is present. Radical procedure may be necessary. Then we do the ossicular and the middle ear reconstruction. The graft was placed from the anterior annulus over the middle ear space and draped over the horizontal semicircular canal to reduce the middle ear space by more than half its depth. Then thus reconstruction of the middle ear and ossicular chain was done. Then do the metoplasty. A metoplasty was carried out whenever the required in the order of the facilitate good marsupialization of the attic and promote the cleaning and adequate post-operative care. We use superior slit technique for metoplasty, and the superior slit is vertical part of the endodural incision extended laterally to open the meatus. This provides a complete visualization of the attic. After completing the surgery, external part of the ESC was filled with the gel foam and Merosil air pack soaked in the antibiotic solution, so as the felicitate patency and epithelialization of the metaplasty. Complete healing of metaplasty was taken 4 to 5 weeks. In the post-operative care, mastoid compression bandage was applied, post-operative antibiotics were given for about the 10 days, and sutures are removed on 7 to 10 days. The first cavity cleaning was done at the 3-week post-operative visit, and Merosil ear pack is removed. Steroid containing drop or regular application of Janssen Violet was used in patient with the granulation tissue. These are the picture of attic perforation, and these are the pictures showing the epitympanotomy. These are the pictures showing the epitympanomastektomy, and this is the picture showing the removal of the cholesteatoma. In the result, total number of patients was 10. Male-female ratio was 63 and 37. Age range 7 to 67 years. Chronic suppurative otitis media with cholesteatoma. Complete cholesteatoma clearance with inside-out approach for mastectomy. Median stay in the hospital is 2 days. Average follow-up 1.5 years. And metaplasty was done in the 55% of the cavities. This is the improvement in the mean air conduction, and the baseline was 43.88 and standard deviation 19.62, and in the follow-up mean deviation was 39.23 and standard deviation 19.76. In the mean airborne gap, baseline 29 and standard deviation 12.78, and in the follow-up mean airborne gap was 25.68 and mean air gap was 12.49. In the discussion, the over study of the 100 patient, male and 63 and 37 female, patient age range of the 11 to 20 years, and like the Gupta et al. Clinical pictures, all patient have otorrhea, and graph was, we have taken 80% graph. Temporal fascia graft 80% and pericordium 20%. Intraoperatively, malleus was eroded in 2.5%, intact in 97%, and not exposed in 2.5%, like the Edelstein et al., in which noted 25% eroded malleus. Stepage had lesion of the 35, similar to the Edelstein, in which 40%, Sade 40%, and the Manrique 26%. Incus was absent in 7.5% patient in our study. Erosion in 67.5%. That is similar to the Manrique et al., in which 69% erosion of incus. And in the Edelstein et al., 46%. In the Sade, incus was eroded in the erosion in the 80% cases. The facial nerve canal was dehiscent in 7.5%. Dural and sinus plate were not eroded, not seen in the Edelstein et al. Series. Erosion of the lateral semicircular canal bulge was seen in the 7.5%. The fistula was covered by the fistula graph 4.9. Lateral semicircular canal fistula were noted in the just like Manrique et al. Osteoplasty was done in the done with auto incus in 42.5% and 22.5% with cartilage. Just like the Manrique et al. Used cartilage in 9.5% cases. In 45% superior slit was employed, make the adequate metaplasty, and 7.5% had conchal and 2.5% had conchal and superior slit. The healing was healing time of the postoperative cavity, 1 month follow-up, no discharge in the ear cavity. 3 month follow-up, 95% cavity had healed, similar to Paprella and Kim. And 6 month follow-up, 100% has shown the complete epithelialization, similar to the Paprella and Kim's. 1 patient had infected wax, 1 was large cavity with granulation. In the postoperative adverse event and quality of life, superior infection and transmit discharge were seen in the 1 cases, 2.5%. Granulation was seen in 1 patient, and postoperative adverse event were 5% comparable to the Chayo-In Q et al., who had 8.8%. In the post-operative audiometry, the mean post-operative air conduction was threshold was 39.23 decibel, and the mean post-operative air bone gap was 25.68% decibel hearing level, similar to the KO study, which noted 48.58 decibel and 22.23 decibel hearing levels. In another study by the Q et al., post-operative means air conduction threshold was 33.55 decibel hearing loss, and the post-operative mean AB gap was 17.88 decibel. The comparison is with the other study, the Gistwood study, number of cases 144, failure rate 17, Abraham et al. 155 cases, failure rate 9%, Sade et al. Number of cases 65, failure rate 20%, Brown et al. Failure rate 30%. In our study, 100 patients and there is no failure. In the entire cholestoma matrix was exteriorized, cholestoma going into the tissue can be removed successfully without restoring to the radical mastectomy. But occasionally, if osteitis or diffuse disease is present, radical procedure may be necessary. This is the follow after 6 months. Blue color showing the healed and healed, red the healed wax, and not healed. No patient in the category of not healed. After 1 year, in the 1 year follow-up, healed 97.5%, irregular cavity 0, metal stenosis 0, healed wax 2.5%. In the conclusion, the inside-out technique tailoring of mastoid bone was done in the direction of spread of cholestoma. A smaller post-operative cavity is achieved with a long run will help in the minimizing problem of the large cavity. The post-operative hearing result and quality of life also significantly improved with regard the recurrent discharge, wax and granulation. The hearing impairment has been found to be significant in the patient who had a problem-free cavity, while excessive wax was in the 2% and debris was seen in the 3%. Thus, we conclude that the overall quality of life provided this technique was very good. These are references. Thank you so much.
Thank you very much. If it's any question from the audience?
I do have a question. In fact, I was wondering if after the intervention, the patients have to limit the decibels they are exposed to. Like, for example, if they go to concerts or other events in which decibels are really high, do they have to limit?
Basically, we have do surgery in the constructive way. So after surgery, we have done reconstruction.
Okay.
Okay, so we have used cartilage graft and bone graft. We do the osteoplasty and maintain the hearing.
So, as I understand, it's similar to a person who has never been intervened.
Yeah.
Okay, good.
Just like to.
Perfect.
So it is the best technique to do the ear surgery.
Perfect. Thank you.
Thank you. If we don't have any questions from the audience, I would like to invite Dr. Li Hu to felicitate Chandraveer Singh with the keynote certificate. Yeah. Yeah. Yeah, I will take with you. Thank you very much. So our next speaker, unfortunately, can't be present because she has some personal problem. So I will take the floor. and I will do my presentation. Hello, everyone. Good afternoon. Thank you very much for the opportunity to be able to present in today's session at the breast conference. The work entitled Comparison of Volumetric Modulated Arc Therapy versus Helical Tomotherapy Planning in a Case of Implanted Breast Tissue Expander. In this presentation, I will present a case report in which I compare different irradiation techniques in a case of implanted breast cancer. So first of all, before I want to start my presentation, I would like to present myself. My name is Gisela Ana Maria Selejan. I'm a medical physicist from Romania. In my fifth year of experience, I have experience with Elekta and Varian machine. I'm a medical physicist in Târgu Mureș. On the map, where is the red star? And also, I'm a PhD student in my second year of study in Cluj-Napoca. On the map, where is the green star? As my research area, it's breast cancer and bolus materials. For today's session, I will have a short introduction about the case report and breast cancer, and also I will describe the planning techniques, the helical tomotherapy and volumetric arc therapy. I have no conflict of interest to this class. As we well know, in world we have every year 4.5 million new breast cancer cases. So we can say it's the most common malignancy in women, according to World Health Organization. For this disease, we have different treatment methods. After diagnosis, the patient can have surgery. By surgery, we can have the excision only of the tumor, or we can have total breast mastectomy. It can be bilateral or unilateral mastectomy. After this step, we can have targeted therapy, which can be hormone therapy or chemotherapy. In this way, we can administrate different type of drugs. And the last but not the least, it's the radiotherapy, where we can have external radiotherapy or internal brachytherapy, which can be at the surface of the skin. These combined correctly can have a good result, and we can I can say heal this disease. So let's see my case. For this study, we made a retrospective comparison between modulated arc therapy, VMAT, and used in our service, and helical tomotherapy used in a different academic institution. We analyzed the case of a 41-year-old patient with right-sided breast cancer who underwent bilateral radical surgery with sentinel lymph node biopsy with implantation of a right-sided ear tissue, and on the left part, a permanent implant, breast implant. For her treatment, we had the adjuvant radiotherapy given up to a dose of 15 gray in 25 fraction to the breast, axilla, supraclavicular, and internal mammary lymph node. For the planning calculation, we have the following data. For treatment delivery, we used an ELECTA linear accelerator, a C-arm, which we can see in the right picture on the right, and this C-arm LINAC is equipped with 2 photon energy and 5 electron energy, and has a characteristic of the collimator system that it's the DMLC agility. It's like a lot of leaves with a thickness of 0.5 centimeter. This collimator has the role to modulate the beam on the shape of the tumor. For the calculation of the plan, we use the Monaco 5.11, which are in the background, which has in the background the Monte Carlo algorithm. For the helical tomotherapy plan, in part, we used his own TPS software, treatment planning software, and these differ a little bit from the Monaco software, because here the algorithm is convolution or superposition. So we don't work on the avoidance of the constraint for the organ at risk. We are working only on the coverage part. The benefit of the tomotherapy is that for the Radixan machines, we have that table which is moving in a craniocaudal position, so in longitudinal way during the treatment. So we can irradiate, and we can have this moving during the treatment. So it's a plus comparing to the C-arm, because when we use a C-arm LINAC, the couch, it's not moving, it's staying in the same position during the treatment. And also here we have a plus, because here the DMLC, it has only 0.25 centimeters, so it's half comparing to the agility collimating system. So when we start to do a plan for a radiotherapy plan, we start by contouring. But before we start to do the contouring, we have to acquisition a CT scan. So the patient was scanned in the supine position with her arms about her head on a breast board positioning support. The contour of the patient shape was created by the auto contouring tools from the treatment planning system, and one radiation oncologist performed the target volume and the organ at risk contour tracing according to the ASTRO guidelines. The clinical target volume was created according to preoperative description of the lesion and pathology, with her addition of the 0.7 centimeter to the tumoral breadth. And the planning target volume was created with 0.5 centimeter margin from the CTV. For who are not, who know, don't know the terms, the CTV is the clinical target volume, and it's when we see the tumor, it's the gross tumor volume. And after that, the next step, it's the clinical target volume, which includes the margins, the microscopic margins of the tumor, which was take out by surgery, or can be localized there. And the PTV is the planning target volume, which includes the margins, the errors, what we can have by the machine, the Linux. In this image, we can see a slice from our patient CT, where we can see that on the right part, we have a tissue expander, and every part of the CT is contoured. We have the organ at risk and the target volume. Okay, so for the calculation of the volumetric arc therapy plan, what we used on a C-arm LINAC, we used 5 partial arcs. 2 arc was optimized on total PTV, which means in that total PTV will include all the planning target volumes: the breast area, the internal mammar node, the supraclavicular, and the axial nodes also. And also we had 1 arc on the PTV nodes, and 2 arcs only on the breast region. Also for this patient, because we had the invasion on the skin, we used a bolus material for better coverage. The bolus material is a tissue equivalent material, which in this plan was put on the surface of the patient in virtual mode, and after that we used it for every fraction when we delivered the treatment. For the helical tomotherapy plan, we used an IMRT deliver mode, so it's intensity modulated radiotherapy. Here we use the same contour, contouring, and also the same CT was exported, and we used the same references for the CT. How I told earlier, here we don't optimize on the constraints. So we don't think about how we can get lower dose on the organ at risk. We are thinking how to get a better coverage. So all the organs was only with beam only. And on the target volume, we had beams, entry and exit beams. For plan evaluation, we had the contact constraints, and also we perform statistical differences by using the conformality and the homogeneity indexes, which are which show how the planning target volume it was covered by the dose. In this picture, we can see the distribution of the dose in sagittal and transversal plans. We can see from this dose distribution that the differences between the 2 plans are not major. So we can say that no one from these 2 is better. So let's see what the numbers say. First of all, we compared the conformality and the homogeneity indexes. The conformality index in radiotherapy, we consider that if it's closer to 1, it's better. And the homogeneity index, it's if it's closer to 0, that means it's the ideal. So we can see that we don't have major differences between the values. So maybe the VMAT technique has a better homogeneity, but if we are considering the conformality, we can see that the helical tomotherapy plan is a little bit better. So our next step was to compare the organ at risk. We can see the constraints given by the Quantec, and we can see our values, what we obtained by VMAT and TOMO. Here we can see some differences. Even if in TOMO we didn't concentrate on the organs and we are concentrating only on the coverage, we can see that we have some improvements. We can see that, for example, for the heart, we obtain with VMAT 5.79 gray, and with tomotherapy it's with 1 gray smaller. So it's a benefit. But with TOMO, we can see that we have higher doses for the 20 volume of the left lung, or we have also higher Dmax on the contralateral implant. So as a conclusion, we cannot say that one of the technique is better than the others, but we can say that in that moment, for us, VMAT was better because we could treat the patient with VMAT, but with helical tomotherapy, we didn't have the infrastructure. And also the benefit of the VMAT technique is that the treatment time, because in this case, we had 5 partial arcs, and the treatment time of the beam on time, actually, it's 338 seconds compared to the helical tomotherapy treatment time, which the beam on time, it's 538 seconds. So it's almost double. So for the patient, it's a benefit if the treatment time is smaller, because the patient has to stay in the same position for a long time. And even if the beam on time, it's only 338 seconds, the treatment actually it's more than 15 minutes, because we have to calculate from the moment when the patient is entering in the bunker and he is leaving the bunker. As a future perspective, we want to compare not only these 2 types of treatment planning system. We want to compare other treatment planning systems, because we know that every planning system has different algorithms, so they are working in a different way. And also we want to implement a operational procedure, because when you have different cases, and nowadays we have more and more cases with this type of one side it's an expander and the other side it's an implant, and we know that we can't have major doses on the implanted breast or the tissue expander, because they can break, or we can cause different issues. So thank you very much for your attention. Do you have any questions?
I do have a question. Well, I'm not an expert in radiotherapy, but as I understood, VMAT and HT, they use both beams. That's right?
Yeah.
In fact, I was wondering if one of them is more selective towards like cancerous tissue than the other one.
Not really.
Not really?
Yeah, because we are using in both of the case we are using photon beams,
Okay.
so they have the same. They are works in the same way. The difference between helical tomotherapy and VMAT, it's like that in VMAT the patient has the position and the C arm it's rotating near the patient, and the penetration of the beam is the same in the both of the case. And the difference also is because, for example, in my case, for the VMAT plan, I had the DMLC, the agility system, where the thickness of the leaf are 0.5 centimeter. And in case of the helical tomotherapy, I had the 0.25 centimeter, so only half thickness for the DMLC, for the
Penetration of the.
no, for the leaf, which are modulating the beams. We used 6 MV megavolt photon energy, so that the penetration is the same from 3.3 centimeter, I can say, from the skin. So this is why I used a bolus material to have that build-up region outside of the body.
Okay. Thank you.
Thank you. This patient was treated in 2020, and she was a young patient, and now she is coming to she is coming to the controls, and she is cancer free. So, but even she is cancer free, she has to came every 6 months, and after 5 years, she has to came back in each year to have a control, because even if we say that it's a cancer-free patient, so you never know that what can happen in the organism. And we have to be careful. As a physicist, I have to be careful to don't have higher doses on the organs, because, for example, in breast cancer, if I have a patient with higher dose on the lungs, I can cause fibrosis or other toxicities to the lung. Or also, if I have higher doses on the heart, I can have there are other issues. So our challenge is to have as low as possible dose on the organ at risk, because if not, maybe I will heal from cancer, but the patient will die in 1 year from heart disease, or yeah, and it's not a plus for me.
How was the damage on the skin?
Sorry, could you repeat the?
How is the damage to the skin after
Yeah.
the treatment? Is this
If the patient is collaborating and he is listening to his doctor, then it's fine, because, for example, when we have external radiotherapy treatment and the patient has the recommendation from the doctor, okay, you have to wash your skin, but you can't use soap or different creams, and if you do this, then you will amplify the effect of the radiation on the skin. So, and in this case, it will appear the radiodermitis and everything. But for example, here we had the skin infiltration also. So we put this bolus material, and in this way, the skin was a little bit affected, because we want this. And also the radiodermitis, it's not that worse than cancer. So we prepare, for example, if the patient is collaborating, you can see after treatment, you can see like the skin become red, and it will be like after a day you stay more in sun. So, but after one day it will
There's no
go.
significant damage to the skin after this.
Yes, yes, it's not
Thank you.
significant. Thank you. Other questions? So this will be a little bit strange, but I would like to invite Chandra Veer Sain to give me the certificate. Just a second. So now we will have a short break. And also I would like to ask you all of us to have a group picture. And we will have also the coffee break. It will be here.
Yeah,
no? Yeah, in the backside of the room. Thank you.
So everyone come here so I can take a picture.
Which one?
It
Dimitra,
is-
Mary. But if you have
It
one-
is PDF file. It is not PowerPoint. Okay, I have it. I have.
if you have it on the stick, it's even better.
This one is like no. This Abir. If you can this to the nursing, this one. If you can move it to the desktop, maybe it's better.
Okay,
In case the
if everybody is in the room, we can start the second part of today. And I would like to invite maybe to go.
Abir.
Abir Diu to have her presentation.
It's a PDF. Yes, yes. It's a PDF. Don't worry.
No, F5, no?
F5 for controller.
No. It's not.
F5. Oh, okay. Well,
Could you click
1 minute?
right click and yeah.
Okay, this one. This one. Okay. Hello, everybody. My name is Abir Dioub. I'm an assistant professor at the University of L'Aquila, Italy. Today, I'm going to talk to you about it's a different subject. It's not. It's related, but is out of all the Congress topic. It's related somehow, but it's not exactly in the medical field. I have a computer science background, so I'm not a medical doctor. So I will talk about conversational agents or chatbots, in the ethics of conversational agents or chatbots beyond, in particular in healthcare domains, in relation to healthcare domains. And we all know that now chatbots have become very popular. All of you for sure have heard about ChatGPT and there exist many other chatbots, and they are used in different domains. And now there are a lot of chatbots used in the medical field for different purposes. I myself downloaded an app which is a chatbot for mental health, or this kind of stuff. So it is important, especially in like healthcare domain. In domains like healthcare domains that they are critical or sensitive to, for these like systems that are based on artificial intelligence to behave in an ethical way. So I will, my presentation will start by a introduction or some background about the machine ethics field, and then I will move to introduce you to the work that I have done with my research group at the University of L'Aquila about the monitoring and evaluation of the ethical behavior of chatbots in all domains. Particularly, I will concentrate today on the medical field. So machine ethics is, as a field, is an emerging interdisciplinary field which draws heavily from philosophy and psychology fields. This field aims at creating machines, what I mean, AI-based systems that are based on artificial intelligence, and they are used in everywhere, particularly in healthcare. There are now a lot of use of technology. The aim of this machine ethics field is to create machines that are ethical, that behave ethically. Especially with the growing power and autonomy of these machines that are based on artificial intelligence, it has become very important to equip them with the capabilities of ethical reasoning. In fact, since the beginning of this century, there were a lot of attempts for implementing ethical decision-making and judgment into intelligent autonomous agents using different approaches, but so far there is no fully descriptive and widely acceptable model of moral judgment and decision-making is there. Machine ethics, or implementing ethics into artificial intelligent agents, help us also to better understand our morality, human morality, through creating and testing computational models of ethical machines that follow a set of ideal ethical principles. Machine ethics approaches can be classified in three categories: top-down approaches, bottom-up approaches, and hybrid approaches. The top-down approaches that are the approaches that try to implement some specific normative ethical theories or set of principles into the autonomous agents or into machines, to ensure that those systems act in accordance with the principles of this theory. While the bottom-up approaches are learning or developmental approaches in which the ethical mental model emerges via the activity of the individual. In hybrid approaches, we try to integrate both approaches to implement ethics into artificial intelligent agents. Moral decision-making, or human moral decision-making, is and judgment is a complicated process involving many aspects. It's a mixture of reasoning and emotions. It is a dual process. Commonly refers to two types of processes corresponding roughly to the distinction between intuition and reflections, or system 1 and system 2 of Kahneman. If you have heard about Daniel Kahneman, famous book, Think Fast, Think Slow. Think fast and slow. And it is highly flexible and contextual and culturally diverse, the ethical decision-making and judgment. So for these reasons, it might be difficult for any single framework to capture moral judgment and decision-making. We need modular architectures that because they are flexible in design and implementation. So in order to implement ethical control and reasoning into systems, into our machines, we need to adopt ethical architectures that are capable of supporting ethical behavior. Those architectures are subclass of agent-oriented architectures with an extra component that is the ethical component. These ethical architectures the ideal ethical architecture should allow the integration of both bottom-up and top-down approaches that I mentioned before. So reasoning and learning principles and case-based reasoning. So this ethical component should be a combination of different types of modules to facilitate reasoning and judgment over a variety of ethical theories or priorities, preferences, and for evaluating the appropriateness of any action, it is safety, or if it is in accord with some ethical preferences or rules, and means if it is ethically permissible. in addition to the unethical adapter, ethical learning module, because the machine, the intelligent machine, or the ethical cannot be like follow fixed rules, because should evolve with time, should be have the ability to learn, because things are changing. Even ethics is changing, even moralities. If you think it's an evolving also field. If you think about the ethics at the time of your maybe grandfathers, is mothers, is different. The society is changing. Also, the ethical, the ethics in the society is evolving and is changing. So learning component is important. So this component should be an ethical overlayer in the overall decision-making and judgment process. So the artificial intelligence based system will like give a decision or prediction. Then this ethical component will be some sort of a filter or an overlayer to filter these decisions or these predictions, whether they are ethical or unethical. Since I'm going to talk about the ethics of conversational agents or chatbots, what is a chatbot? Is a computer program or an artificial intelligence software that can simulate a conversation with the user in natural language via auditory or textual methods. It is typically used in the dialogue systems for various practical purposes, including customer service, information acquisition, or in health care. I'm sure everybody have used some chatbot. All of us have used this in one way or another chatbot, maybe trying approaching some company, customer care, because most of the companies and the customer care part, they have their chatbots, or using like messaging systems, or maybe ChatGPT you have maybe tried. But from the technological, this is the important in the design and in the implementation of the system. From the technological point of view, a chatbot only represents the natural evolution of question answering system, leveraging natural language processing. So these systems, as I said, are often deployed via messaging apps, websites, or mobile phone apps. They also can be integrated in cars, television sets, or in the form of a standalone devices such as speakers, or in robots. So they have physical, some sort of physical body. But the chatbots raise many ethical questions. Maybe if you are following issues on ChatGPT, you heard about the discussions or issues on ethical issues that are raised by such systems, from privacy to data ownership to abuse to transparency and so on. How those systems or how those chatbots behave have the potential to influence how an organization that own this chatbot can be perceived, and unethical behavior from these chatbots can lead also to customer mistrust and litigation issues. The behavior of those machines, machines here, I refer to chatbots or conversational agents, should be guided by their organization codes of ethics and conduct. But building or implementing or enforcing these codes of ethics, codes of ethics and conduct in these systems is not really an easy task. Let's move to healthcare domain, ethics in healthcare and conversational agents in healthcare. In 2020, telehealth experienced an unprecedented uptake around the globe, with the COVID-19 pandemic acting as a catalyst. The COVID pandemic accelerated, in fact, the introduction of virtual healthcare delivery in many countries. It also prompted the rapid development of many other diverse technology-enabled systems and processes for delivering virtual healthcare to patients. One of these technology developments is the widespread uptake of conversational agents in people's lives, and these now also have many health applications, healthcare applications. In fact, those systems, by enabling better accessibility, personalization, and efficiency, they have potential to make our life easier, to also to improve patient care. They have many good aspects, but they have also many ethical concerns. So healthcare ethics, what is healthcare ethics? Is the a collection of principles that guide doctors, nurses, and other clinicians in providing medical care. It covers how providers treat patients, because it's healthcare is a critical domain. It requires a strong ethical code to provide guidance in making decisions, ethical decisions. However, these codes of ethics cannot always provide hard and fast rules, straightforward rules to implement, to take decisions in health care, but they provide a general framework for decision making. And now with the GDPR, the conversational agent industry has been affected, because a conversational agent, before it is deployed, it should be a GDPR compliant. So the motivation behind the work that I'm going to introduce you for monitoring the ethical behavior of chatbots in health care. So in the healthcare domain, maybe you know that in the ethics of medical field, in the principles or the biomedical the ethics of biomedical ethics based on 4 principles introduced by Biochamp and Childress in the 1990s were adopted for the medical ethics or the healthcare ethics. The principles were, since they were introduced by those 2 scientists. Those principles are autonomy, non-malfeasance, beneficence, and justice. Such as for principles, for ethical principles, that they form some sort of framework for ethical decision making in the medical field. As you can see, they are very general and abstract codes. It's difficult to put them in practice in their abstract form. They might also conflict. There are a lot. So they might. It's quite difficult when one wants to make a concrete decision in real life, ethical decision, how to follow these general laws, how to use these general rules. They might. So when we are faced with a situation, in a concrete situation in real life, in which that we need to take a decision, an ethical decision, for example, a doctor, how to apply these 4 principles in real life situations. They might also, as I said, conflict in many situations. For example, there is a famous example in the world of ethics about the conflict between such general rules. For example, a care robot that has the or personal assistant, whatever you want to, that has the competence to take care of an elderly patient. And one of the tasks that should remind this patient to take his or her medications. If this robot like remind the person to take his medication, and this person refused to take the medication, what I should do, or what this robot as an assistant and then as a healthcare assistant should do. Should insist, should force somehow. So it, in this case, breaks the autonomy, the principle of autonomy. If insists, if it insists, but it's for the benefit of this person. At the opposite, if it does not insist, this might lead, if this person does not take her medication, might die or lead to more bad consequences. So it is now, I don't break autonomy, but so there is a conflict between autonomy. This is an example about the conflict between these principles, in this case between autonomy and beneficence or non-beneficence. So these principles apply also to a wide range of situations. They are subject to also interpretations and may have different meanings in different contexts. So it is quite difficult, if not impossible, to define them in a manner that they might be applied deductively or in a straightforward way. And it's difficult, or if it is not, it's almost impossible for experts to define intermediate or procedural or practical rules to cover all possible situations to which a particular code applies. So we need, in fact, in reality, we need practical rules that apply to different situations, and they cannot be applied, they cannot be defined previously, because it's difficult to fully specify in advance all possible scenarios that our care robots, now I'm talking about care robots or AI-based systems that are used in healthcare. So the challenge is that we are trying to address in the work that and the architecture, let's say, and the technological solution that I'm going to present you is to how to monitor the ethical behavior of chatting agents in dialogue systems. The evaluation process, I'm not going, of course, to go in technical details of the design and the implementation. They are based on the elaboration of facts extracted from the documents containing the codes of ethics and conduct that are proper of a given domain in this or organization in this case healthcare domain, and from real life situations concerning pertinent ethical decision making and judgment. These facts are used to elicit rules for ethical reasoning. So the proposed system for monitoring dialogues in chatbots for ethical violations were implemented as group of agents and a multi-agent systems. So they are a set of agents. In this picture, you can see the architecture of the system inside the box system container. So it is the practically the ethical component or the ethical overlayer that occupy or take care of the ethical evaluation, monitoring and evaluation. While so we have a client that contact through this work is still in it is, let's say, early stages, so we handled only the texting or chatting via text messages. So a client or a patient that start chatting with either could be also a way to monitor also humans that respond to patients or persons. So is chatting, writing in her chat interface, a question or to the chatting agent. Chatting agent will respond how the process of the evaluation or monitoring is done. The text, the chatting text is extracted, then is translated into a formal language, technical details, in the formal language to be able to reason over this, because for a machine, a little bit of technical details. Machines cannot reason over natural language. They need a language that they understand, the programming language or formal language that they can understand to be able to reason using techniques, artificial intelligence techniques for reasoning over this. Then this the text, after it is translated into a formal language, it is the reasoning process applying. We will here apply the techniques, the artificial intelligence techniques, to evaluate whether the response of the chatting agents to the client or the patient is ethical or not. This is done following rules, ethical rules that this system have. If we don't have the ethical evaluation rule to evaluate the chatting scenario, the learning process start to learn a new rule, new practical rule for evaluating the case scenario at hand. Then the case the scenario will be evaluated, and the evaluation is ethical or unethical will be passed to the ethical monitoring agent. This ethical monitoring agent will notify the chatting agent about whether, saying that in the moment that the only like control that is implemented is just notifying. So the ethical monitoring agent will notify the chatting agent that your answer is not ethical. So, but this agent can also, with we are planning to improve the system, so more control can be practiced by this agent or the chatting agent to block the unethical answers before they are given to the client or to the patient. So this system, as I said, is still in its preliminary phases. Was tested with a small data set of examples because which was created manually by us. In fact, the scarcity of examples or data sets for learning is one of the main challenges in the ethical domain in general. It was discussed in many events and conferences that I participated in. So to conclude, some of the advantages and also limitations of this system. So this ethical system, as you have seen, as a multi-agent system, so as a set of agents that relate to each other and communicate with each other to achieve the ethical evaluation, and monitoring is acts as a separate ethical component or ethical layer for evaluations that can be integrated in any chat bot or any conversational system. This provides many advantages from the engineering point of view. So the ethical component has access to all data using for ethical evaluation, and use this data to provide justification also for a given ethical evaluation to humans, which should lead to accountability. The possibility also to adapt this component to change in circumstances and needs. So implementing it as separate ethical layer, so it's not integrated part of the system, make more flexible to adaptation for the different cases. In addition to the possibility of implementing more than one version of the ethical component in the same agents, the possibility also to verify the functionality of the ethical component in independent way from the operation of the main autonomous agent, then reusability, support also reusability and standardizations. So the this is okay. We'll skip. I mentioned before. This is related to advantages related to the technologies used. Maybe I will not talk about this. It's more. It's about technologies that you maybe use. Not. Don't know. For the patient to trust a care conversational agent or a care robot, also the justification or the explanation of the reasons behind its actions is important. And this is one of the advantages of our approach, is the comprehensibility of the logic, because we use logic-based approaches. Again, about the technology used that is transparent by design or interpretable by design. If you have heard about things like concepts of ethics or trustworthy AI, so transparency, explanation are important aspects. So this ethical component acts as a governor, evaluating the prospective behavior before it is executed by the agent, and the outcome of the evaluation can be used to interrupt the ongoing behavior of the agent by either prohibiting or enforcing behavior alternatives or behavior changes. Some of the limitations of the systems, the actual we are working on this is the one of these limitations I've already mentioned is or challenge, let's say, is about the limitations of the scarcity of examples or limitations of training data sets. Then there are other limitations in the current version, the translation module that translates from natural language to formal language, which is unstructured programming, is limited. I have designed a translator, a small translator that is able to translate certain types of English language sentences, but we are planning to improve it or use more professional or more complex translators. Then it is a supervised. We were just talking about this. The human oversight is, we consider from the technical point of view, because we aim to fully autonomous machines, the machines that do by their own without the help of a human. But lately there was a lot of discussion in machine ethics that, especially by the European Union and also on the international level, about the importance of human oversight on artificial intelligence, especially in the critical domains like health care. So our system needs a supervision of a human expert, ethical expert of the domain, human ethicist in the medical field that evaluate the supervise the machine in learning phase, because our agent is an evolving agent that learn over time, learn new rules from cases, and this process is done under the supervision of human expert. So it is not fully autonomous, let's say. We believe that is for the sake of transparency, ethical decisions should be guided by explicit ethical rules determined by competent judges or ethicists, or through consensus of ethicists. Our approach provides support for developing these ethical rules. Thank you. If you have any questions, please ask questions. I know that the topic is out of is related somehow, but it is not exactly in your specializations, but ethics is important everywhere, especially in the medical field. So
It would
yeah.
be interesting to see how that could be used. Do you know when people just ring up for an ambulance because they feel sick, not because it's an actual emergency? Can it be used to,
Well, sorry, what do you mean? Why people call?
no, there's been some studies done where
Yeah.
people call 000 in our country,
Yeah.
or the emergency number,
Yes.
because they feel sick. It would be good if they could, if you could use the artificial intelligence to determine
Whether it
whether
is
it is an emergency
is it or
or
not?
not,
Yeah.
and deploy that phone call elsewhere.
Yes. Yes.
Emergency lines
Ye-
open.
There is a study, but I don't know now remember like exactly I cannot give you the reference, but there is a study that using artificial intelligence, evaluating the, let's say the breath, the tone of voice of the person who called, to evaluate how it is really an emergency case. There is a work on this, but needs to be improved to be really credible, because it's not easy to really evaluate from like one is calling breathing from the breath from this, but there is work on this. Yeah.
I have a brief question. Are you worried about self-diagnosis when you use this kind of technology? Like it leads patients to a self-diagnosis that might not be good for them?
Well, these systems, to tell you something, these systems are this kind of recommender systems, not only like with chatbots, it's used also by doctors. And can help. The technology again can help either people to be more let's say that they can take care of themselves at home without involving for anything the doctor, as she was saying, that calling for something stupid is not for calling for a case, calling the emergency, making like a lot of a team of emergency people work or come to your home for something that does not it's not really an emergency. This could happen, the other thing could happen. The importance is the responsibility of them. And of course, this is an important concern, but these systems should be, cannot be deployed just like this. Any system should be designed in a responsible way. And responsible way means if it, based on a really credible information, and this system should also recommend to the patient to contact the doctor. So, for example, if you have a chatbot, your let's call it your personal assistant, you are saying, I have some cough, for example, this might tell you, but at a certain point, this system, if it is designed in a responsible way, should tell you now, at this point, if your cough is you should contact your doctor. I cannot do something. The importance is they can help a lot. They can reduce the pressure on the health hospitals and healthcare firms and organizations, but they should be really developed in a responsible way.
Thank you very much for your kind presentation.
Yeah.
And I would like to ask Corinne Chavez to solicit. And also, we had a question on the chat.
Okay.
How do you handle the difference in ethic among different cultures?
Yes. So this is one important concern, that these systems are our approach help to like learn rules for different domains and also in different cultures, in different countries. That's why there should not be systems that are designed in general way, based on like specific ethical principles that are fixed, rigid. This should not be. This kind of cultural, the diversity between cultures, or also the context, also cultures, and even groups, small groups, or whatever you want, organizations, domains. This could be handled by like learning, of course, adopting an ethical general framework, like in the case of medical domain. The framework is the four ethical principles of Childers of biomedical ethics: autonomy, beneficence, non-malfeasance, and justice. This general framework, but specific practical ethical rules should be learned from from cases, from scenarios, from interactions with the users or patients in this case, or users that are going to use the system. And if we want to talk more in general, in any country, the system should be developed in the country, interacting with persons from this country, or since it is about culture from this country. So and they should be supervised by ethicists in this area, in the area, or in the country, so they know the ethical values of this country, or this domain, or so it should be like this. We should not have an international ethical, let's say, rigid principle. Of course, there are common things, but there are also many differences. So there should be the possibility to learn new rules, of course, under the supervision of specialists in each country or in each domain. I hope I answered your question.
I hope so.
Further,
thank you. Now I would like to ask Maria Malay to have her presentation.
which one? Okay.
Hello, everybody. Nice to meet you all here. I come here to introduce to you my research, which I did a couple of years ago. This is Quality Improvement Initiative, introduction of the cross-disciplinary safety breathing in the operating theater before operating list commences. This next one. I would like to introduce myself. I'm currently working in the BlackRock Health Galway Clinic operating theater department, and I have 40 years experience as a registered nurse. BlackRock Health Galway Clinic is private hospital with 147 beds, and approximately last year we performed over 17,500 surgery. Like never before, I realized how important it is to have good communication between all members of staff. I'm not a native speaker of English, and I moved from Poland 2005 to Ireland. And my colleagues, which I'm working with, they come from different parts of the world as well. So I would like to say that this is not only difficulties to learn new language, but I find as well how different culture we represented in this small place like where I am working currently. Many of us carry on to the workplace their own culture, their own behaviors, attitudes, and this has to be moderated by the proper communication. As a senior nurse, I believe there is always room to improvement, better communication between multidisciplinary team members, management, and departments of the hospital. My research question to be, which were investigated, it was, does safety breathing reduce miscommunication and improve team dynamic in the multicultural hierarchized theater department? What type of barriers can be present during the implementation and continuation of safety breathing before operating list commences? How the practice of safety breathing improves patient safety and overall satisfaction and collaboration between perioperative team members. Galway Clinic evaluate every year a survey which continuously identify issues related to interdisciplinary communication as among the most challenging aspects with the workplace. The researchers works within operating theater settings where competent and clear communication is paramount to good workplace morale and realizing safe and efficient clinical practice. Frustrations concerning poor communication are commonly voiced among the staff and suggested that impact negatively on the climate of surgical team and efficiency of the work within the operating theater environment. In this research from evaluation between 2017 and 2019, we indicated that the worst aspect of working at the organization was poor communication, which took 6 of other 12 questions. I would like to bring here a little bit available knowledge. I chose 3 of them from my research. One is improving patient safety is inextricably linked with correct communication. The Joint Commission on Accreditation of Healthcare Organization, JCAHO, stated that there is a close association between poor communication and medical errors. Sutcliffe et al. Make this a little bit wider, more complex problem because they stated that poor communication is not only simply the result of poor transmission or exchange of information, but that communication fails are particularly complex and may relate to hierarchical differences, concerns with upward influence, conflict roles and role ambiguity, and interpersonal power and conflict. In 2006, Rigard et al. Implemented a safety intervention to promote proactive communication in a hierarchical environment of operational team. They conducted a study involved over 300 preoperative interpersonal team briefings, and their findings find it that the setting preoperative discussion, communication, sort out all these discrepancies and resolve all the problems before the first patient arrived to the theater department. And rationale of my research was the purpose of this research was to propose and trial an initiative that would improve interdisciplinary communication skills with very busy operating theater department. Working in the multidisciplinary and multicultural environment with hierarchy and variation in the scope of professional duty and dependency can be stressful, pressurized, and can pose a significant risk of miscommunication between busy, hardworking staff. Ineffective communication among team members can put a big impact towards vital information regarding to the safety of the patient. The aim of this research was to project and investigate the impact of standardized implementation of the safety tool, like safety breathing, on perceived team communication and collaboration in the operating theater department. Objectives was to determine the proportion of operating theater respondents who have previous knowledge, who had previous training, who had previous experience with the safety breathing or surgical safety checklist, and eventually to evaluate the experience of staff in using the 5 steps to the safer surgery tool, which was just safety breathing as a first step to perceive impact on the team dynamic, enablers, barriers, utilization, and impact on patient safety. The methods. The methods quality improvement for the quality improvement initiative was introduced to the participants the new tool which can be used as a standardized approach to interdisciplinary communication. And taking a team approach to this, it was proposed that implementation of this project research will result and improve the care, listening skills, understanding of the value of enhanced communication within the workplace. I would like to say a few words about the key people. Before I started my project, I did my research in any occasion, even though during the breaks in the canteen. I would like to know if this is really worth it to start. And I've got the feedback from my colleagues, all the stakeholders, that absolutely communication is this using any tool for improving communication in the theater department. This is very, very important for us, and they encouraged me to do this. Key people, they were my colleagues, they were surgeons, they were anesthetist doctors. I was talking as well to more advanced key people like analysts, like IT engineers, because the project to be successful had to be prepared very well. So for this roll out my safety breathing, I use, I can't, no, it's, I use the Edward Deming cycle. So it was plan, do, check, and act. So I had to ask myself a question: I will do it? What has to be done to make this project successful? Who will be involved with that? I develop and communicate with the people. That was the next step. I train the staff and implement standards. I self-assess how I am doing in this stage, and acting, and I'm acting. So I prepare. How is this? This is just my training session. On this picture, we have two healthcare assistants, myself, and my colleague, which is a scrub nurse. One of them is holding my just developed the brochure, which was sent to all the participants. The sample size for this survey was 50. Gain the level of support of resistance to alternate participant journey in the theater department through the additional safety breathing tool. I developed 12 questions in the questionnaire among the participants. They were divided equally for positive, negative outcomes, previous knowledge, and process feedback. Each safety briefing took 5-10 minutes before first patient arrived to the theater department, and involved between 4-7 members of the staff, including the surgeon and anesthetist consultant, 2, 4, 3, 4, 5 up to the type of case, scrub nurses and healthcare assistant before the safety briefing took the place. The safety briefing checklist was constructed this way that everyone had opportunity to ask the question to any member of the staff. Relevant information about the patient, like details about the allergies, about the blood loss, about implants, about the health condition, equipment issue, staff issue, about the list which could running of the time. Everything was dissolved in the morning before the list started. There was no any problems to ask any any party of the team ask the question. Healthcare assistant could ask about the positioning, previous surgeries, like for the orthopedics positioning, when for the hip replacement, is this a very necessary example question. The other hip was done, or an limbs replacement was done in the past. So they had opportunity to sort these problems as well. This is just a safety briefing which was provided by continuously already by the gynecologist, which brought this tool from UK, as she was trained there. And we started to do this between two teams, gynecology, orthopedics. But because like I said before, there was big applause towards the improving communication in the theater department. So voluntary, another 2 theaters joined to us. It was ophthalmology and it was a cardiovascular group. They wanted to do the trial as well. General demographics: 49 staff completed the questionnaire, feedback survey, and attended to educational session. I sent to all staff 83 emails with the instruction informative apps as informative information with the brochure. So apps were set up with the informative brochure as well in all computers in the theater department, 27 computers. 9 visualization posters were set up in each theater, including holding bay. 49 people were trained face to face, and 50 questionnaires feedbacks I've got. Totally 30 safety briefings were performed during my research. Positive outcomes. Over 4 question asked, 91% of respondents agree that safety briefing will improve both communication within the team and the safety of the patient. Negative outcome, 75% disagreed that safety briefing was too time consuming and not necessary. So when we can look at this, then actually negative outcomes feeding positive outcomes, because people still believe that 75% believe that this is no time consuming, it's necessary to have this tool as I presented for my team. Previous knowledge, 71% of respondents stated that they had either knowledge or used the safety briefing in the previous employment. Process feedback, 73% of respondents stated that they felt that the education was satisfactory. Data management. Quantitative data was converted to the graphical presentation. So I use Likert scale with 5 options. It was strongly agree, neutral, strongly disagree, and disagree. And for the purpose of undividing responses, we pulled all these positive, negative, and neutral responses into 3 groups: agree, disagree, undecided. Quality data allowed participants to speak out using free text. Here we took the answers and created a listed table to better allow us to map the responses into specific categories. This type of data collection allowed us a deeper understanding of the position of the responders, and not just look at the numbered quantitative responses from above. You can see here the presentation about the first question. I choose only few questions because this presentation would take about 70 slides, over 70 slides. So I reduced this only for the few my research graphical presentation. Example, Q1, I have experience with safety briefing in previous employment. So we can see that 56% agreed with that. 4 undecided, and disagree 40. 44%, this is a number which makes matter compared to the question 7. The safety briefing is time consuming and delays the start of the list. And we can see disagree with the exactly 56%. So there's correlation with those which had previous experience and training and did this before. And again, 22% agree there's time consuming and delays the start the list, and 22 undecided. This is again this 44% which were unsure before. So this is, like I said, this is big correlation. between this experience. Now, another question, it was question 10. It is clear who be completing the WHO World Health Organization surgical safety checklist. And we have more or less the same numbers. For 54% agree that they know who is completing, who is responsible for that, and 24% disagree, and 22% undecided. Confusion, it was meant to be completed the checklist in the operating theater. The percentage of the previous experience in using the safety breathing, with 46 of those asked unsure of this process. Now, responsibility of using WH surgical is you are responsible. Again, the same number. The team is responsible for using WHO checklist. 53% they were sure who is responsible for that. They had previous training, and these numbers kind of continuously come back as a feedback. The next is confused situation, and it didn't show up the bottom, the green line, but this is that one which didn't respond. Just,
the laser.
yeah, it's here. Anyways, doesn't show up the last line. Oh, okay. So the surgeon is responsible, anesthetic nurse is responsible, scrub nurse is responsible, and 16%, this is the green part, it didn't show on the bottom. This is what people didn't respond because they were unsure, they didn't know. So who is responsible for the performing of the surgical safety checklist? Understanding the core value of teamwork. 46% of respondents for Q10 were unsure about the responsibility of performing surgical safety checklist in the operating theater. After limiting the list of respondents to only the nursing team, so we take out surgeons and consultants, anesthetists. The results show that 50% knew that team is responsible for performing surgical safety checklist. 31% of respondents were unclear as to which personnel the WHO checklist related to. 16% allocated usage to the surgeon, 15% to various other process areas within the surgical sphere, and high level 16% respondent they understand the understanding of the responsibility of the WHO checklist at all. From this research, the findings were strongly correlated to proceeding outcomes other countries. 91% of respondents were sure that safety breathing improves communication and patient safety, and 75% respondents disagreed that safety breathing is time-consuming or not necessary. Using of the WHO surgical safety checklist has been associated with a significant reduction of postoperative complication after inpatient surgery. Conclusion. The purpose of this research was to explore staff experience and implementation of safety breathing in a multicultural, multidisciplinary operating theater. Globalization in nursing is the fact, and we have to find the way to prepare nurses to work in the multicultural society. The operating theater is a workplace where technically technically complex communication skills must be used when delivering care through multicultural and hierarchical multidisciplinary teams. Positive relationship with the theater team is essential for generating a positive culture and atmosphere that promotes and releases patient safety. Using clear standardized protocols for communication like surgical safety checklist help to avoid mistakes with passing relevant information before, during, and after procedure. Safety breathing checklist before commencing surgeries should fill the gap before the operating list start. This should be used as a routine for patient safety, smooth teamwork, and standardized communication, which builds safety climate in the operating theater. Thank you. Any question?
Thank you very much. We have time for a short question.
For this analysis, did that involve like actual people from many countries? And if so,
Yeah,
which
yeah.
countries?
From all over. In this small place where I am working, we have people from all over the world, from Africa, from New Zealand, from Australia, from Canada, from Poland, from Czech Republic, from Slovakia, everywhere, from France, from Italy as well. So I'm not sure about Sweden, but I think that we have somebody as well.
But have you already noticed like language was a barrier like for communication?
Yeah, when I came to Ireland 2005, that will be 18 years ago, my English skills were good at all. You know, I find out this is so stressful to work in the interdisciplinary team. We are working we are presenting multi-skill in the theater. You are not prepared to work only one theater, example, only ophthalmology. You have to move to all this type of surgeries. We have urology, we have cardiovascular surgery, we have cardiac surgery. You have to work with each team. So this is why I said it was so important to find the key people so I can blow off all information. So this is why I set up so many emails, 83 emails. There was no discussion that somebody didn't know in the theater, even the recovery. However, they weren't involved directly to this research, but they knew what I am doing. And it was important for me that nobody will be surprised, even though central sterilization, they've got the email as well, what I am doing. They were actually, they give me support as well. However, they weren't involved with this project. Sorry, I'm a little bit stressed because of this performing, but I hope that I answer your question.
Yes, thank you.
Thank you.
Thank you very much. Now I would like to invite Mitra Kalimeri to felicit Maria Valli with this certificate of appreciation.
Thank you.
Now our next speaker will be Martin Sornes.
Can I find my slides
Yes.
in here?
Martin. This one?
Let's see, there we go. Yep.
What is
If I,
No.
okay, touch.
This one touch. So no need to
Okay,
worry.
great.
So you can.
Great. Well, dear scholars. I'm an audiologist, and this is my first public talk. So what would a better place to debut than before loads of people that academically outrank me? Not to mention that my speech will attack the groundstone of audiology. So let's start out with a lie. I'm not nervous at all. I'm a Norwegian audiologist with a bachelor in technical audiology, with experience from both public and private clinics. Back in 2007, I was awarded an entrepreneurial scholarship from my university for my IDO mobile audiology. In 2008, I vaguely described the product we will be talking about today in my bachelor thesis called Speech in Noise as an evaluation tool, different options with a futuristic perspective. Let me try to create an image in your minds. Picture the inside, try to visualize a VR helmet and remove the glasses. And then you have a signal speaker approximately 40 centimeters from your head. And you got speakers for noise, also approximately 40 centimeters from your head, in which forms a circle around your head. And that is Hero Medical's first product. So please keep that image in your mind for the rest of my speech, because this is hopefully the future of audiology. I got a few ideas in the field of audiology. Home audiology is something I find interesting, and as audiology is a field that is ready to make the transition from hospitals and conventional clinics into the comfort of the client's own home. I was actually one of the first audiologists to no, not yet. I'm yeah, I'm having very few. Okay. So yeah. Let me see. And I was awarded an entrepreneurial scholarship for this back in 2007, and today the world has proven me right, as all the giant hearing aid producers have released their own telemedicine app. That makes me a proven visionary. I also see the need for a learning platform for hearing aid users, as studies show that clients miss out on up to 75% of the information given in the first consultation. Easily accessible, personalized quality information about maintenance and problem solving for hearing aids can increase the quality of life for 430 million people in the world with a disabling hearing loss. It's often small gaps of knowledge that makes the hearing aids end up in a drawer instead of on the client's ears. There's a lot of information for hearing aid users out there. Hearing aid producers got different stuff, some user organizations, but you need kind of the one place to go to. But that's, yeah. In February this year, I incorporated Hero Medical Inc. as a Delaware C Corp. This company's goal is to develop the new standardization for audiometry. I actually pictured this, yeah. Let's see. And this is the state of the art of audiology today. This is where what masked bone conductor looks like in a clinic today. I think it's you know, I pictured my my equipment before I set foot in an audiological laboratory, and when I finally entered one in 2004, I thought it was a joke because it truly looks like something from a candid camera when you are watching the performance of a masked bone conductor for the first time. How it looks is irrelevant. I think we all can agree that it's the functionality that counts. So let's go back to the birth of audiology in the years after World War II. Of course, there has been innovations before that, but this was the time we started to use the term audiology. And some very smart men came up with a way to test hearing, pure tone audiometry. If they had known that their invention would be the state of the art for almost 8 decades, they would have been proud. Pure tone audiometry has been the main source of information of audiology for almost 80 years. No field is stronger than its source of information. That also applies to audiology. You know, I'm standing here with a Bachelor of Audiology, so many probably question the depths of my knowledge, and yeah, you're probably right. I don't know it all, and I don't pretend to either. I know speech in noise, I know a little bit about Beckesi audiometry, and I spent years thinking about the new audiometry. Some of those who listen may have competencies in other specific areas, but what is important here is not what we know, it's what we don't know. That's really important, what we can learn. And let's face it, pure tone audiometry does not provide us with a well of opportunities anymore. That's why we need to rethink audiology. And what better time than now? There are tons of research out there. Let's bring it all together, and in doing so, let's focus on client outcomes. Let's make it easy for the ends to find the right diagnosis. Make a system that has AI algorithms that propose new tests based on current measurements real time. If we can assemble the brightest minds in audiology, psychoacoustics, electrical engineering, software developers, we'll even bring some psychoacoustics, even bring some neurosciences. I'm confident that that will result in an audiometry for the next 8 years. We got the basis, Hero Medical's first product, and we got perfect ways for product development today in the industrial metaverse. You know, a lot of clients today come to a hearing clinic and claim that their hearing has deteriorated. And we test them with pure tone audiometry, and the results show normal hearing, you know, and we send them home telling them they are wrong. But we can't really answer that unless we test hearing also with noise, because this this statement, the pure tone audiogram can show normal auditory thresholds with only 10% of auditory fibers intact. This is from an article from 1993. So this is nothing new. We know that pure tone audiometry is inadequate through tons of scientific research. Yet we stick to it. This is not something we can escape. This is not about our neighbor. This affects us all. This very second, about 1.5 billion people have some sort of hearing issue in this world. 430 million have a disabling hearing loss. And we will all belong to that group once we get old enough. This is about you and me. There is a probability that approximately 100% of us will have a disabling hearing loss if we grow old enough. That's nature. Today's audiometry is perhaps more about the medical perspective. We need to turn it to the client perspective, because audiology is about clients. Without them, we wouldn't have a job. That's why we need to measure what is really important to them. And the biggest pain point for clients is how they can hear in noise. In silent surroundings, even some people with a profound hearing loss can function fairly well. It's in noise the problems occur. This evolves around clients' ability to function in the real world. And this measures and measuring this ability clinically can have a huge impact on client outcomes. I'm not saying that every client who says their hearing has deteriorated is right. I'm saying we need to measure this, because if we don't, we can't really say. And I believe client perception is one of the best indicators that something is wrong. The speech audiometry gives us an indication, but if the difference is 10 decibel from the last test, do you really understand what that means in terms of speech intelligibility and how noise affects it? It can make a huge difference. And to understand this, we need to measure speech intelligibility in noise in a free field. We need an audiometry that indicates where the problem is located. Pure tone audiometry identifies if the hearing loss is conductive. I believe those diagnosed with APD today just are the top of the iceberg. We need to get indicators built into the new standardization for audiometry that ensures we will perform the right tests for the specific individuals. This is so that people can get the help they need as fast as possible. Because if we have a good audiometry, we can kind of send those with processing problem there, you know, with presbyacusis, old age hearing there, and yeah. Speech intelligibility score in noise is very important to measure, not just for the ones where we suspect APD, but for everyone. This has no direct correlation to the pure tone thresholds, and the discrimination tests we have today performed through headphones with without noise are not adequate. You know, clinical tests for this are already developed. Hagerman and Hint both have developed 5-word synthesis for this purpose, and the speech in noise test is gaining popularity. Today, free field setups involves 2 speakers 1 meter from the test person, and it's gaining popularity. Today in Norway, 12% of audiometries are performed through free field pure tone audiometry. The challenge of, Biologic was onto something here with their Hint Pro system that was released in 2007. My invention would have been a perfect fit for their system, but for unknown reasons, at least to me, they decided to shelve that system. Back then, free field audiology was considered to be the future of audiology. And I believed it then, and I still believe today that they were right. There really aren't no way around it. We, however, need to come up with a solution that makes the test results of these tests comparable. And the only constant factor here is the client's head. I believe it's possible to make this speaker hat. We just need to test what can affect the measurements. The industrial metaverse allows us to test on what extent room size will affect the measurement. The same goes for furniture, head size, placement in the room, etc. And depending on these test results, we can compensate signal to room size and come up with a perfect product design without even building the physical product, and ultimately develop the new standardization for audiometry. This test does not give us a traditional thresholds. These tests measure signal-noise relation. But if we test at a given signal-noise level, they will be comparable. And this very simple formula can give us the answer on how how well the hearing aid works. This is from my bachelor thesis in 2008, and this is a very simple way to test the effect of the hearing aids. As this test, this is speech reception threshold in noise with hearing aids, and speech reception threshold in noise without hearing aids is the effect of the hearing aids in decibel at the tested level. But they won't be comparable if you if the testing conditions isn't the same. So we need kind of to work around the decibel scale, because the decibel scale is a logarithmic scale. So we need kind of, or somebody who's better at mathematics than me need to figure out a way to calculate the decibel back to Pascal and then into percentage, which then will be comparable. So I need to find where I am. I'm freestyling a bit here, so yeah. The sensitivity of these tests can be discussed. It's not very well, but the more lists you are performing, the higher the sensitivity. So it will also give us as audiologists a possibility to test the effect of new new innovations on hearing aids. You know, we can test by coupling the new feature in and out. So we test first without a lot of sentence list, and then when you have it in again. This can't be done in scale. You know, this can be done for one person, or one audiologist can do these tests for one person and kind of share the results with a lot of other audiologists. But this is not a testing way for scale, but it will provide us with more knowledge, and it will put the hearing aid producers information to the test. You know, today hearing aid producers come to us with data sheets and present us with data sheets on how the hearing aids are working. This system will let us do that clinically, so we don't have to trust the hearing aid producers anymore. We don't today either, but we have no chance to test it individually. In addition, this can provide us with a clinical directional hearing test, which I personally think it's a shame we don't have in place in 2023. This, however, requires more speakers in the product. There can be 4, 7, 15, 31, 63, 127, even 255 small speakers for noise in this system. I am still fairly confident that if that we can make this a very low in weight. We also have to go through some old-fashioned rules that don't align with the time we live in. Today, every audiometric device is required by law to be calibrated once a year. This system can be self-calibrated with a microphone probe hanging down in the middle of it. So there's no need for some professional person to come and calibrate it every year. Yeah. But back to audiometry. Not many have dared to challenge the unprecedented place of pure tone audiometry. Many audiologists have asked the question, why do we still use it? Mostly once. It's like swearing in church. We collected so much data on this method is the most frequent answer. Or often followed by a look that tells you wrong question, don't ask again. We have always done it this way is maybe the most dangerous sentence in our language. And it's my claim that this is not the best way to measure hearing. It's old-fashioned, outdated, and not relevant. Audiology is very conservative. Change does not come easy. That makes it even more obvious that we need to rethink audiology. Not only have the technological progress opened new pathways, audiology is kind of screaming for renewal. The deeper you go into this, the more shocked you'll be. The argument of data collection is solvable. Actually, we should create a database with most of the audiograms in the world. This requires us to make a simple anonymizing software for the hospitals and clinic to run it through before uploading it to a database. This way we can all benefit from the data. We can make AI algorithms to analyze the audiograms. This supplemented by research on the findings can uncover many new disorders. You know, it's easier for computers to find similarities in 20 audiograms out of 1 million than it is for a human being. For a human being, that is impossible. I believe such a project alone could lead to the discovery of many new diseases. Computers find similarities and humans do the research. Today's technological progress opens for so many options. We need to mix audiology with the progress of the rest of the world. Make an audiometry aligned with the time we live in. And I am confident that we can produce both better and more relevant audiometric tests if we take advantage of that. My vision of free field audiology considers the authentic way we hear, and therefore it's a natural base to start from. The data from the common database can be used to develop algorithms that can help you in terms of diagnosis. For example, if a carotid notch is detected, this might be autosclerosis, and yeah. So if the algorithm suspects a certain diagnosis, tests to verify this will be suggested. This will make both your and the audiologist's job easier. The only Nobel Prize winner from audiology, Hungarian George von Békésy, did try to challenge pure tone audiometry. And it was a very good try. He did, as I am sure you're aware of, not receive the prize for his audiometry, but for the research on hair cell. One of the pluses with Békésy audiometry is that it measures frequencies and decibel levels. In pure tone audiometry, we are kind of guessing the line between the testing frequencies and decibel levels. It's not optimal, even though many will say it's adequate. I would like an audiometry where we can read the threshold for any given hertz signal and decibel level. Békésy audiometry can produce that. Another interesting effect of Békésy audiometry is that it provides us with a difference limit. And I am excited to see how that will play out in a free sound field. I believe we also need to look towards other fields of medicine to develop the audiometry of the future. I believe the new audiometry can be found in the intersection between free field audiology and neuroscience. I have been speaking to some neuroscientists lately, and there's been progress made in that field also. It should be doable to mix free field audiology, Békésy audiometry, and neuroscience to develop audiometry. A combination of neural responses and client response. This way we can get an accurate and relevant audiometry that can provide us with a lot of answers. So, yeah, that's I forgot a few. This is a quote that helped me all the way through this, and this is kind of very important, I think. The electric light did not come from the continuous improvement of candles. That's Oren Harari. He's a late professor from the University of San Francisco, I think. And I love this quote. So thank you. That was all I had to say today.
Thank you very much, Martin, for this presentation. We don't have time for any question, but if it's any question, we can discuss at the lunch, during the lunch. And also, if have somebody from the online, you can let the questions in the chat.
Okay.
And Martin will give the answers later. Also, I would like to invite Chandra Singh to give the certificate of appreciation to Martin. Chandra? Okay, thank you very much to everyone. This is the first part of our today's session. Now we will have a quick lunch break and we will meet in half an hour here.
Not half an hour, it will take 1 Everyone can watch it. It's a live stream.
I'm okay. Take care.
Just,
So should I do that
Yeah.
now?
yeah.
Perfect. Thank you.
I talked to Jill. In fact, there's no. I suggested that. But I also thought, I think that, he might be asking some of this.
Normally, there are two people
Good internet.
that don't pay the glass of wine. Two more people.
Honestly.
Yeah, I think you and other people.
Okay.
One is mine. So you and you.
Yeah.
Is it possible to go to restaurant for pay? Yeah, please.
Okay.
Thank you very much. On va y arriver.
So, like, I asked him, I told him about the situation. And I suggested that he ask someone with internet, because I don't have for connecting with cable internet. You understand? I'm very, very sorry. And they don't have cable. Yeah. And but I also sent him.
Okay, and your presentation was.
Okay, so
you
have like 3 other
Yeah, yeah.
Yeah.
Yeah, but they already,
Okay,
they are
okay,
aware.
it's fine.
Okay.
Old fashioned, yes.
In fact, it's the same issue. We have to- It's not stable. and
No, now
disconnected.
it's stable because.
Yeah, but the wires. Yeah, yeah, that's.
We don't have wires.
Yeah, we don't have wires anymore.
Yeah.
That's the problem, yeah, exactly. We asked for a room without wire and they are still.
Thank you. It's a main place TV shows preschoolers. Station. And it's an actress called Penny. My grandfather is a secretary before she became an actress. And that's how I got the name.
No.
Okay. So let's start the second section of this day, second part. And let me introduce Dimitra Kalimeri to have her speech.
So good afternoon, ladies and gentlemen. I'm very glad to be here today. My name is Dimitra Kalimeri, and I am the infection control specialist of Athens Medical Center in Greece. In this presentation, we will see indicators which are pertinent to the infection control and infection prevention in our hospital during the last 5 years. The Infection Control Committee of our hospital adheres to protocols mainly to CDC. It meets almost every month and has established standards and procedures not only for the infection control and prevention of our hospital, but also to check the extent that medical staff conform to these protocols. The coronavirus pandemic has radically changed a lot of processes concerning hospital infection control and prevention, such as charting of multi-resistant pathogens in hospital, reasons of patients' isolation, waste disposal, training of health professionals, and continued change of nurses. In the beginning, the total number of patients who have been hospitalized in our hospital the last 5 years will be mentioned. We can see that in 2018, 18,750 patients have been hospitalized. In 2019, 19,105 patients. Fewer admissions in 2020 because of coronavirus, 16,233 patients. But the last 2 years, it seems that we become to normal daily life. And last year we had again 19,121 patients. About the isolated patients during the last 5 years. In 2018, 719 patients were isolated. In 2018. In 2019, 680 patients were isolated. In 2020, 440 patients were hospitalized in isolation rooms. And last year, in 2022, it seems again that the patients are more, 375 patients. The isolated patients can be divided into 3 categories. The first category concerns patients infected by multi-resistant bacteria and virus. The second category concerns patients who came to our hospital from other hospitals. And the third, smaller patient category consists of international patients. At this point, it's worth mentioning that a test screening takes place for the second and third category. So,
Sorry, I will put you.
Τι έκανα?
They didn't share the screen.
So let's see the isolations per clinic in 2022. Out of 19,210 patients, 375 patients were isolated. 139 patients in pathological clinic, 112 children were isolated, 38 patients in hematology, 12 in oncology clinic, 11 in lung clinic and cardiology, and less in neurology, surgical, neurosurgery, vascular, and urological clinic. The current slide shows the distributions of isolated patients on the basis of the cause of infection. If we compare before and after coronavirus pandemic, we can see some interesting indicators. For an example, in 2029, 65 adults patients were isolated because of influenza. In 2021, only 2 patients were isolated because of influenza, because almost it disappeared. And last year, again, 47 patients were isolated because of influenza. The same we can see to pediatric clinic in 2019 and before coronavirus pandemic, 86 children were isolated because of influenza and 72 children because of RSV. In 2021, 1 year after the coronavirus pandemic, influenza disappeared and only 3 children were isolated because of RSV. Last year, again, influenza was the first reason for the children to be isolated. Since 2020 and coronavirus, our hospital, according to the health ministry policy, had to hospitalize patients coming from public hospitals. Most of these patients were already infected when they came to our hospital. And the bacteria cases are as follows. 17 patients, when they came from other hospitals to our hospital, was already infected with multi-resistant Klebsiella pneumonia. 7 patients of Acinetobacter, 5 patients of Staphylococcus aureus, 6 patients of Pseudomonada aeruginosa, 7 Clostridium difficile, and less 2 patients from Enterobacter, Serratia, and 1 of Salmonella. 3 patients carried multiple bacteria. The rate of transferred patients with multi-resistant pathogens is as follows. 64% came from public hospitals, 19% came from rural public hospitals, 10% from nursing homes, 6% for private sector hospitals, and 1% for abroad hospitals. I told you before about the third category, the international patients. International patients is the category of patients that have been in our country the last month, and for some reason they come directly to our hospital, so there is a screening test for them too. Here again we compare before the pandemic and after the pandemic. In 2018 and 2019, 4 patients from Egypt were infected of multi-resistant Staph aureus, 3 patients of Saudi Arabia with Proteus, and 4 patients from Libya was already infected of malaria. And 4 patients from England were infected of Staph aureus. In 2020 and 2021, there were no international patients because of coronavirus. And last year, in 2022, 2 patients that came from Nigeria were already infected by Klebsiella pneumonia. So all these patients are hospitalized in single rooms, and there are precautions for medical staff, visitors, and relatives out of the door. There are posters with all kinds of precautions: airborne precautions, contact precautions, droplet precautions, special contact precautions, etc. So the medical staff can be informed about the kind of precautions, and also we help visitors and relatives to know what exactly they have to do before they come to their rooms. The current slide shows the consumption of antiseptics, and so we can see that in 2020, there has been a huge increase in consumption of antiseptics. Then it seems that it comes to daily normal life, as I told before. The same indicators for antiseptic soap, but the soap, it seems that every year it's higher. Maybe we learn to wash our hands. Okay. As I told you in the beginning, the infection committee has established some procedures to check the extent that the medical staff conform to the procedures and the processes. So we use the luminometer and the ATP monitoring system. About hand hygiene. Hand hygiene is globally a matter of paramount importance concerning the infection transmission. So in our daily visits in all the at the hospital, in the clinics, we use luminometer and check the load, the microbial load of hands, and also we use the UV light to check if they use correctly the antiseptics. There are posters with the 5 moments of hand hygiene everywhere in the hospital, posters about surgical hand washing, and for every surgeon, a gentle reminder about hand hygiene under shine. This is under shine, and many indicators about doctors' hands, registered nurses' hands, stretchers bearers, and administrative assistants. In fact, this is a tool to concern as I told you, the microbial load before and after hand hygiene. Now, according to CDC environmental checklist, again with ATP system, this slide shows the distribution of bacteria among high-touch and low-touch surfaces. It's obvious that with an acceptable limit 500 RLUs, all the high-touch surfaces as IV poles, bathroom knobs, room doors knobs, tray tables, telephone, etc. The indicators are the double than the acceptable limit. So we have to advise the cleaning staff again and again to clean more thoroughly all these surfaces. This slide shows the percentage of the personnel conformity to the basic protocols of nursing care. The red color represents not acceptable cases, and the blue color represents the acceptable cases. The most common faults are about hand hygiene, recycling, and empty or out of order containers of antiseptics. Just a few words about waste management. Since 2015, our hospital has been certified with ISO 14001. It's a green hospital. In fact, this certification demonstrates the ecological and environmental friendly attitude of personnel. According to World Health Organization, the infectious health care per patient must be about 2.4 kilos per patient, and our indicators were good to 2019, with the infectious health care about 2.8 kilos per patient. But unfortunately, after the coronavirus, it's higher. It's 3.5 kilos per patient. So according to World Health Organization, we have to improve the indexes. For all of these patients in isolations and the patients that have central lines, chlorhexidine patches, chlorhexidine caps and sprays. These are the original forms for patients' central lines check. And a few words about nosocomial infections, the yearly COTI rates, yearly clumsy rates, SSI rates, and VAP rates. As I told you before, several patients were transferred from public hospital because of coronavirus to our hospital because of coronavirus pandemic. And many of these patients were already infected. So if you see the clumsy rates, accepted clumsy rates that are still in low indicators, unfortunately, the SSI rates are a little bit more in the two last years, 2021 and 2022, and the VAP rates in 2021 and 2022. But generally, about nosocomial infections concerning our hospital has the lowest percentages versus other Greek hospitals, according to the Greek Infection Committee, of course. All these conclusions have been published in international journals, not one, not two, not three or four, but 6 journals, and we are very happy about this, and we're very proud. So we are trying very hard to keep going strong. Thank you very much. Yes.
Do you believe that during the coronavirus, everyone was so cautious about spreading illness through wearing masks and washing their hands, and so therefore there was a dip in a lot of infectious diseases? But now that coronavirus is starting to disappear, people have relaxed.
Yes.
And aren't as cautious.
They have relaxed, that's for sure. I think that as I saw you, all the infections like RSVs and the flu, etc., disappeared, but unfortunately, the nosocomial infections are higher.
Okay, thank you very much.
Thank you too.
Camila, I would like to give you this certificate of appreciation your work. Yeah.
This is not your name. Thank you very much.
So, and now I would like to invite Li Hu, if I pronounce correct, to see her presentation.
Thank you.
Just a second. Yes. Yeah. 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 Working. And some. Okay. Let's think this. Okay. Like this.
How can I share this now?
It's sharing the screen.
Oh, it's sharing?
Yeah.
Okay.
And you have just.
I think we stopped sharing. Just
we stopped sharing. Yeah. Okay. Let's.
It's shared now.
Is it shared?
Yeah, yeah,
Oh, okay.
screen, full screen share.
Okay.
You need to share, it's already shared.
It's shared. Yeah. Yeah.
Share.
Do a full screen then.
Just put it like that. You can use this one.
Right.
This
Yeah,
You have to put the foot on the.
point. Okay. Yeah, I got it. Thanks. I think it works. Thanks. I'm Lei Huo. I'm a pathologist from a cancer center. So I like to, while my research or clinical research interest is in biomarkers in breast cancer. And I'm gonna talk about our study on PTEN in triple negative breast cancer. So here's an outline of my talk, and I have nothing to disclose. So triple negative breast cancer is an aggressive subtype that comprises about 15% of breast cancer. It lacks expression of ER/PR/HER2. So for systemic therapy, the standard is chemotherapy and also the more recently implemented immunotherapy. So to develop effective targeted therapies,
is an active area of research and also for clinical trials. And PI3 kinase pathway is the most commonly activated pathway in TNBC. It's thought that altered genetic activation of PI3 kinase pathway occurs in about 25% of TNBC in the primary setting, and probably higher in metastatic TNBC. So the activation is thought to contribute to tumor growth, metastasis, as well as drug resistance. So here are some of the essential components of the PI3K pathway. The PI3K kinases are a family of lipid kinases, and in breast cancer, the most important is class 1 of this family, which is composed of a regulatory subunit and a catalytic subunit. So upon activation of PI3 kinase, it would phosphorylate PIP2 to form PIP3. And upon binding to PIP3, AKT is phosphorylated, and it can subsequently phosphorylate downstream proteins, including mTOR. And so there's the end effect is cell proliferation and cell survival. So P10 in this pathway is a phosphatase. It would dephosphorylate PIP3 to PIP2. Therefore, it negatively regulates the pathway through dephosphorylation of AKT. So there are mechanisms to activate this pathway in TNBC. And the most common mechanisms are yeah, there it goes. So the most common mechanisms of the pathway activation in TNBC include activating mutations of the PIK3CA gene, which encodes the catalytic subunit of PI3 kinase, or activating mutations of AKT1, which encodes one of the 3 isoforms of AKT, and or inactivating alterations of the P10 gene or loss of P10 protein. So P10 has been identified as a tumor suppressor implicated in various cancer types, including breast cancer. In Cowden syndrome, which is linked to germline mutation of P10, women have an estimated 25% or higher risk of lifetime breast cancer. Interestingly, P10 mutations are only identified in about 5% of breast cancer, but loss of P10 protein by immunohistochemistry has been reported in up to 40%. So this indicates that other than P10 gene mutations, there are other mechanisms involved in loss of P10 protein. So the mechanisms could be promoter hypermethylation, could be decreased copy number, or could be translation regulation or post-translational modifications. And also, it's been shown that the PIK3CA mutation and loss of P10 protein, they tend to occur separately in breast cancer, although they're not entirely mutually exclusive. So the PI3 kinase pathway genomic alterations actually occur more frequently in ER-positive breast cancer than triple-negative breast cancer. However, loss of P10 protein is highly associated with the triple-negative phenotype. So all these findings underscore the importance of evaluating PTEN protein loss when we assess the PI3 pathway alterations in TNBC. There have been several reported clinical trials of PI3 kinase pathway inhibitors in TNBC, and the major ones are listed here. So these trials, they have been done in either primary or metastatic TNBC patients. The patients could be early stage or advanced stage or metastatic. And most of these trials, in most of these trials, the PI3 kinase pathway inhibitor was used in combination with chemotherapy. And most of them have evaluated genomic alterations in the pathway, either with or without PTEN protein loss. So some of these have shown significant improvement in progression, disease-free survival or overall survival. So suggesting that targeting the PI3 kinase pathway is a promising approach in TNBC. So several practical issues have emerged from these clinical trials. These are a few of them. First, in the trials that did protein evaluation, they allowed the testing of a freshly obtained biopsy or archival tissue, meaning the evaluation of PTEN protein could be done in any time point during the patient's disease. So it could be done in the primary tumor, it could be done in either pre-treatment biopsy or post-treatment surgical specimen. It could be done in recurrence or metastasis. However, it's actually unclear whether PTEN protein would stay consistent during the course of the disease. So, or you know, when you test different specimens, whether you would get the same result, that's unclear. The second issue is there's not really a standard as to how you define PTEN loss, PTEN protein loss. So in these trials, there's a wide range of what people have called PTEN loss. And the third one is there's very little information regarding how the genomic alteration of PTEN versus the loss of PTEN protein correlate with each other. So in the study I'm going to present to you, I'll show you how we try to address the first and the third problem. We actually have some data on this one as well, but due to the sake of time, I'll briefly mention it at the end of the talk. So, so in this study, we try to answer two clinically relevant questions. The first one, does loss of PTEN expression by IHC remain consistent in different tumor samples over the course of the disease? And to study this, we did IHC on paraffin sections, and the clone we used, the antibody clone we used is from Dako, and it's generated using the last 100 amino acids from the C-terminus of PTEN. And the second question we try to address is, does the copy number analysis by next-gen sequencing would add value to the evaluation of PTEN status, possibly as an alternative to IHC? Because now, especially when patient has advanced disease, very often they have genomic or genetic studies, so that information is actually available. And if we can use that instead of IHC, that's a step less for the patient to get treatment. So for this one, we have whole exome sequencing performed on fresh tumor tissue using a Illumina sequencing platform. And in this platform, we have a probe against each exon of the PTEN gene. So overall, the study design is we would look at tumor from prior to neoadjuvant treatment, and we would look at a tumor tissue from post-treatment surgical specimen. So we look at the correlation or concordance of PTEN protein expression by IHC. And at the same time, we have profiling or sequencing results from the pre-treatment tumor and post-treatment tumor. So we look at the copy number variation and try to correlate that with the protein loss. All the patients in this study have enrolled in the Artemis trial, which is a investigational trial in our cancer center. All the patients had been diagnosed with stage 1 to stage 3 TNBC, and after the initial diagnosis, they were first treated with 4 cycles of AC, and then they had evaluation by imaging, either ultrasound or MRI. Those who had more than 70% of tumor volume reduction would continue with Taxol as standard therapy. Those who had less than 70% of tumor volume reduction were offered with a phase 2 clinical trial. So all the patients had surgery where the residual disease was assessed. So for our study, we took 2 time points. One is prior to treatment, we had biopsy material, and those we had PTEN IHC, and we had sequencing data. And also we had tumor tissue at the point of surgery, and we also had IHC and sequencing done. So here is our study cohort. So basically, from patients who had surgery, we excluded those with complete pathologic response, and we also excluded patients who didn't have enough tumor material for evaluation. And a few patients did not have good staining results, so those were excluded. So we ended up with 96 patients. They were diagnosed between 2015 and 2020. So all of them had pre-treatment and post-treatment breast tumors for IHC, and that was done formalin-fixed paraffin-embedded tissue. Among these, 33 patients also had post-treatment lymph node metastasis, and they were stained by IHC. 76 patients had pre-treatment breast tumor samples for sequencing, and 17 patients had post-treatment breast tumor samples for sequencing. And the sequencing was done on fresh tumor tissue. So here are the results. When we compared PTEN staining in paired pre-treatment and post-treatment primary tumors, we found 5 patients who had discordant results. So 4 patients had loss of PTEN in the pre-treatment tumor, but positive staining in the post-treatment tumor. 1 patient had loss of PTEN in the post-treatment tumor, but positive staining in the pre-treatment tumor. Here's one example. So the brown indicates positive staining, and the light blue is the background staining. So in this particular case, the pre-treatment breast tumor had positive PTEN, but the post-treatment tumor, which is in this area, had loss of PTEN. And the staining you see here, these are stromal cells, which serve as the internal control. So then next, when we compared PTEN staining in paired post-treatment primary tumor and the lymph node metastasis, we found 3 patients with discordant results among 33 total. So 2 patients had positive staining in the primary tumor, but loss of PTEN in the lymph node metastasis, and 1 of them had the opposite. Again, here is one example. So this is the post-treatment breast tumor with staining of P10. But here, in the lymph node metastasis, there's no staining for P10. So for all these 3 patients, the post-treatment primary tumor had concordant result with the pre-treatment breast tumor. So the difference is between the post-treatment breast primary versus the post-treatment lymph node metastasis. So as a possible mechanism to explain the discordance, we looked at heterogeneous P10 staining in the post-treatment primary tumor, just to see if you could have a tumor with some positive staining, some negative staining. Then the hypothesis is during the course of the disease, maybe one clone would be lost over time. The other clone would become the dominant clone in the subsequent specimen. So when we did that, we did find in seven patients, there's heterogeneous P10 staining in the primary tumor. And this is an example where this is one post-treatment primary tumor. This entire field is tumor. But if you look at the P10 staining, half of it has positive staining. The other half has loss of P10. So the corresponding pre-treatment breast tumor actually showed loss. So next, this is the correlation between the P10 copy number analysis by next-gen sequencing and the IHC results. So we had 76 tumor samples from 76 patients who had sequencing data. 2 of these patients, which are indicated by the red arrows here, they had somatic mutations in the P10 gene. One of them had a very small deletion, but it resulted in an immediate stop codon. And the other one had a single nucleotide nonsense mutation. So both of these actually showed loss of P10 by IHC. So that's a very good correlation. Then we had 2 tumor samples that were equivocal in the pretreatment tumor, so we couldn't really put this in the statistical analysis. But the remainder 72 patients, we had statistical analysis to look at the correlation between copy number versus IHC result. And it showed that the IHC positive group had a significantly higher copy number compared with the IHC loss group. However, if you look at the dot plot, you realize they overlap here, right? So if we found this, we actually used a cutoff based on previous studies. So, and this is log2 ratio. Let me backtrack a little bit. So this is log2 ratio. So in the P10 loss group, the log2 ratio for the copy number is negative 0.79, which is about 1.17 in copy number, and the normal would be 2. And in the IHC positive group, the log2 ratio is such that it's equivalent to a copy number of 1.78. So the p-value is highly significant. So if we use a log ratio of negative 0.4 as a cutoff, all the IHC loss patients would have the lower copy number, but 14 of the 60 patients who had positive IHC would also fall into this category of low copy number. So they're not entirely separated based on the copy number. And we had a much smaller cohort for the post-treatment tumor samples. We had 17 patients. So we did see a trend that's very similar to what we saw in the pre-treatment. However, it didn't reach statistical significance, probably due to the small sample power. We only had 2 patients with IHC loss in this comparison. It's interesting to see one of those cases I showed you earlier with heterogeneous staining. It actually fell in the low copy number category. So in summary, we did kind of 2 analyses in this study. One is we looked at the concordance between pre-treatment and post-treatment tumor samples in Piton loss by IHC. So we showed that in the primary tumor, there's a 5% of discordant rate between the pre-treatment and post-treatment tumors. And there's a 9% discordant rate between the post-treatment primary tumor and the lymph node metastasis. So here, I just want to briefly mention that we did look into the issue that I showed you earlier in terms of what would be a good cutoff for Piton loss. So we took a very stringent cutoff. So we didn't allow any staining in the tumor cells. And that's the data I just presented you here. And on the other side, we took a very loose category, which was used by some of the clinical trials I showed you. So we allowed 50% of tumor cells to stain for P10. So basically, if you have a 50% loss, that's considered a low versus otherwise it's considered high. So when we apply the less stringent cutoff for P10 loss, we actually didn't see a big difference in these discordant rate. So instead of 5 and 9, we saw 8 and 9. So pretty much stayed the same, which was kind of surprising to us because we thought if you're not so stringent about the criteria, you may see a lot of discordant, but actually that at least it didn't show in our study. And so we saw a 7% intratumoral heterogeneity for Piton loss in primary tumors. And again, with the second part of the study where we looked at Piton expression by IHC and compared that to copy number variation by next-gen sequencing, there's a positive association for sure. However, the 2 categories, they actually overlap in copy number. So our conclusions from the study as well as the clinical implications of our study is if you have a clinical trial, you want to include P10 protein evaluation, you actually need to be aware that in less than 10% of the patients from different tumor samples, you may get different results. So from the study design, I think it should be clarified in the patient inclusion criteria what patients you want to include. If you have a negative result, or if you have a P10 result from one specimen, and if the patient has multiple specimens, you need to test other specimens to get a concordance for the patient to be included or excluded. The other implication from our study is we may be able to find a cutoff for copy number by next-gen sequencing, where we would know that the higher copy numbers, patients with higher copy numbers, they don't need to be tested by immunohistochemistry for Piton loss, because it's very likely that they would have Piton loss based on our results. However, the ones with low Piton copy numbers, there's really a mixture of patients with Piton loss and the ones with Piton positive staining. So those patients would still need to have immunohistochemistry to test their protein expression. I would like to acknowledge all the team members for this study, and especially we're very grateful for the patients who have enrolled in the ARTEMIS study. So these are some additional references, and I'm happy to take any questions you have.
Thank you very much. If we have any questions from the audience?
I do have one question.
Sure.
In fact, we are working also with breast cancer, and I was wondering if you paired your immunostaining for your histological cuts with other methods for quantitative calculation of PTEN loss.
I'm sorry, the question is,
Did you use other methods paired with?
with the, I
yeah.
see. No, we
Like-
did not. It's a pretty standard way. So clinically, that's what's used by immunohistochemistry.
Okay, so you don't use like quantification of like RNA or other.
No, I think the correlation with between RNA and protein probably would not be very good, because for P10, it's pretty complex how the protein loss would correlate with expression. So I think because there's so many steps of regulation after transcription, the correlation between RNA and protein probably would not be ideal. And for protein expression, I think in a research lab, you may be able to use other ways to detect it, but clinically, those are not very practical.
Yeah, okay,
Right.
thank you.
Thank you.
Okay.
Thank you.
Thank you very much. I would like to invite Dimitra Kalimeri to facilitate the group. Our photograph to take some pictures. Thank you. Okay, now our next speaker is Chaim Kaplan. Let's. What is it?
Okay. I would like to share with you my experience with Motiva implants, ergonomics Motiva implants with covered with Dermacell over 5 years. I have nothing to disclose. According to the US Department of Health, about 268,000 new cases of breast cancer are in the States every year. 75% of them prefer to do immediate reconstruction after surgery.
Sorry, I will interrupt you because the screen is not shared. Just a second. But I don't know why. I received a message from the organizer from the online. Yeah, now it's fine.
Okay?
Yep.
Okay, about 81% of the patients prefer to do immediate reconstruction will do it with a silicone implant. According to the American Society of Aesthetic Plastic Surgery, there was an increase of 74% in the number of reconstruction that the plastic surgeons are making in the last 20 years. Silicone is the most common alloplastic material we use. Unfortunately, today we don't have an implant specially designed for breast reconstruction. We have only for breast augmentation, and that's what we are using. For many years, I used my implant of choice was the Allergan Style 410. It's a stable form implant, but since Allergan withdrew from the market due to the possible link to ALCL, I changed to use the Motiva Ergonomics implant combined with ADM. We changed our paradigm of reconstruction up until about 2019, we use the texture implants. We use the form stable implant like Allergan. The placement was subpectoral or retropectoral, and the lower pole usually was covered with ADM, acellular dermal matrix, or with muscle. And we use quite a lot of tissue expanders, and the reconstruction was always done after radiation treatment. But we have many issues with that regime. There was implant malpositioning, especially after radiation. There was a tendency for a cephalic shift of the implant, especially after radiation. As I say, the form stable implant, they look very nice standing up, but when the patient is lying down supine, the implant is just sticking out in an unnatural way. There was always animation deformity. Upon flexing the pectoralis muscle, the implant would move laterally and upward along with the skin. Some patients had chronic pain, which presented as limited shoulder and arm movement. And some patients had chronic discomfort, which actually they discovered that only after we moved the implant from a retropectoral plane into a prepectoral plane. And they would say, listen, I feel much better now with my chest, with my shoulder. There is, of course, the association of the texture implant to the ALCL. And we had a high rate of capsular contraction rate, up to 25%, Baker grade 3 and 4. 4 is the highest. Now, the new approach, we use smooth surface implant. We use a prepectoral placement. The implant is covered and fixed to the chest wall with ADM, and the reconstruction is done prior to the radiation treatment. Actually, we want to finish all surgery before the patient gets the radiation, not after. And we use a direct to implant reconstruction. We almost never use tissue expanders now. There are some factors that influence the mastectomy incision. The surgical oncologist, of course, the site of tumor, previous lumpectomy, scars, previous surgery on the breast, radiation treatment, the type of mastectomy, if it's a skin sparing or nipple areolar complex sparing mastectomy, patient preferences. We have also to consult the patients. Sometimes they have their own ideas. And of course, the pre-op aesthetic of the breast, the size of the breast, symmetry, ptosis, and the positioning of the nipple areolar complex. The Motiva Ergonomics implant came to the market on 2013. They were made, of course, for breast augmentation. They are smooth implant with almost no incidence of ALCL. They have a very low incidence of capsular contraction, less than 1%, but that's on breast augmentation, significantly lower than Mentor and Allergan, which is the American companies for implants. However, all these numbers refer to breast augmentation and not for breast reconstruction, which we don't have yet data. I did 141 patients with covered, the implant was covered with Dermacell, which is a human decellularized regenerative tissue made by LifeNet, and about 14 patients by the ADM was Alloderm made by ABV. About the Motiva Ergonomics implant, it's a very soft implant. The softness is very similar to a normal breast, and it changes shape according to the body movement. The very low incidence of capsular contraction keeps it very soft. However, there is a problem of tissue adherence, and it requires meticulous fixation of the ADM to the chest wall. If you don't do it properly, the implant will move. That's why I require the patient to keep with sports bra for 3 or 4 months. Oh, this door is a problem. Okay, now you see a patient 1 year postoperative. She had a 475 cc Motiva Ergonomics implant. I use the Demi implant. Demi implant is an implant with less projection than the full implant. It looks more naturally. So she had one post skin-sparing mastectomy on the right side. On the left side, she has mastopexy for adjustment. You see her standing up, a very natural result. And lying down, the implant takes the shape of the chest wall and is pulling to the side just the same as the normal breast. Now, how do we measure which implant will fit the patient? There are many ways to do it, but the best way that I found is, beside measuring the breast footprint, I measure what I call the anterior vertical envelope, this measurement. And this measurement, we mark the lower pole and the upper pole of the breast, like that. And then we measure this size, and we compare it to the measurement on the implant. Motiva on the catalog has these numbers, so we can calculate, and we order one exactly the same and one below and one above. On radiated patient where the elasticity is very low, usually we order 2 or 3 smaller implants. We use the ADM. This is ADM Dermacell. We use for large implant 2 big pieces, for small implants, smaller, 1 big and 1 small ADM. They're very expensive. And we suture them together with a braided non-absorbable suture. It's a Dicron or Ethibond 2.0. We do it on a side table, as you can see here. Very tedious, but we have no choice till now. Move on. And then, I didn't start. And then we cover the implant with the ADM, a full coverage on the anterior surface, and the coverage on the posterior surface is just like with a purse string suture. That's enough to keep the implant within the ADM. This suture is a Vicryl 0. It's an absorbable suture. It has to stay there just for a while until it gets adherent to the tissue. We don't push it too much because we want to keep it soft. And then we mark the implant like that so we know where to put the stitches. We put the implant inside the pocket that was made by the general surgeon. The first stitch will always be on the lower fold, which we call IMF, inferior mammary fold. And we count the ribs, and we do exactly the same on both sides. And the second stitch will go on the medial side, 1 or 2 centimeters for the medial, and then we sit the patient up to look for symmetry. We check the symmetry of the IMF and the symmetry of the midline, in the midline. When these 2 points are exactly in the same, the rest will be exactly the same. In cases that we keep the nipple areola complex in place, we put 3 what we call parachute sutures up in the upper border of the breast, and then we tie them to the ADM and push the ADM in and do the same thing exactly. We start with the lower suture and the medial suture. Now the LifeNet has a bigger ADM, 20 by 10 with a 1 to 2 expansion, so we can use 1 piece to cover the whole implant. I'll show you my data on the Motiva implants. It was published in the Journal of Plastic Reconstructive Aesthetic Surgery. There were 267 breasts, normal patients, with all kinds of disease and problems. Most of them had BRCA mutation and carcinoma. Some of them had radiation treatment before. Some of them had radiation treatment after. The size of the breast was around 400 on the mastectomies and around very near 400 on the implants. So you see, we don't have to use tissue expander in order to get most probably same size breast. our total complication, the major complications that needed reoperation was 5.6%. I had 4 cases that there was displacement of the implant, where I learned to do a better meticulously placement of the implant. There is a problem of rippling, which I address later a little bit. About 4% of the patient only complaining about that. Hematomas, seromas, the capsular contracture in a non-irradiated breast, Baker 3 and 4, was very low, almost 1.5%. We had 7 reoperations because of mastectomy skin necrosis, and we had a very low incidence of infection, 1.87. Among them, there were 1 mycobacterium and some pseudomonas. Some of them were treated with antibiotic, and some had to get explant of the implant. We didn't have any red breast syndrome. On the irradiated patients, we had 37 breasts irradiated. 8 of them had capsular contracture, which means 21.6%, which is quite high. By changing the placement of the implant from retropectoral to prepectoral, we prevent the shifting of the implant post-radiation. So patient get radiation, the implant stay in place, even though it gets a little harder, but it doesn't move upward near the shoulder. We did a post-operative breast Q, and we found that, we had about 69% of satisfaction with the breast, very similar, a little higher than the literature show for Allergan implant, which were the implant we used before. Some case presentations, a 45-year-old, the incision was an inverted T incision. The incision goes along the breast and in the IMF, like that, inverted T. Motiva ergonomics 425. You see her before and after. Most of the implant, as I say, are DEMI implant. On ptotic breast, we had a problem because we can't really put an implant in the size of the breast and get a nice breast because the implant stays too high. So what we do, in this case, where the breasts were empty, we put larger implants, 360 cc, to fill up the breast to get a proper shape. Another case of IMF incision on reconstruction bilateral. You see the breast, very natural looking breast. And another one, 16 months later, IMF incision. This is the before, this is the after. This is a large breast, 550 cc Motiva ergonomics. Again, inverted T incision, a very large breast. The inverted T incision seems to be a little, gives a better shape than a transverse incision, although it has some problems with healing the T junction. Patient before mastectomy, after transverse incision for skin sparing mastectomy, nipple reconstruction, and after the nipple areolar reconstruction with tattoo 2 years later. Very natural looking breast. This is another way to solve the problem of ptotic breast when the patient wants to keep the natural nipple areolar complex. We do a 2-stage operation. First stage is either mastopexy or reduction mammoplasty. And about a month later, we do mastectomy through a vertical incision and put the implant in. This is what I said about the rippling. You see here it's very hard to see, but there is like a wave shape of the skin. It's a problem when we use soft implants, especially when the tissue on top of them is very thin after mastectomy. The only way to solve it is by fat injection to this area or to the upper pole in order to make the tissue a little thicker. Another case 1 year after, 265 Motiva implant, and another one. And another case, 550, she wanted bigger breasts and fuller breasts. She got what she wanted, nice breast. This is a case of a patient that had lumpectomy on the left side with irradiation treatment. About a year, 2 years later, she came in with a new cancer on this breast. She had a skin-sparing mastectomy with the implant reconstruction and the adjustment of the other breast by mastopexy. In conclusion, our experienced Motiva ergonomics round implant covered with Dermacell ADM shows good natural result for alloplastic reconstruction with very low incidence of complication. Thank you.
Thank you very much for your presentation. Do you have any questions?
Nice presentation. That's my question regarding former post what's your experience about former breast lymphoma?
Breast lymphoma, the ALCL.
After
I had only one case in my practice of ALCL. In Israel, I think we have so far 8 cases, proven cases with the ALCL. And the one that I had, the presenting symptom was like in the literature, swelling of the breast, large swelling with fluid, which was a CD30 positive and ALK negative. And we did a total unblock resection of the capsule with the implant, and that's it. She had nothing later. We did all kinds of tests. About 2 years later, she decided she wanted new implants. Put new implants.
I don't have a question, just a comment. I'm very impressed by your work.
Thank you.
I know that you're presenting like the results for this kind of implants, but your work is excellent.
Thank you.
What determines whether it can be pre-pectoral or post-pectoral?
There is a pectoralis muscle here, and before we thought that we need a better coverage for the implant. So we used to raise the pectoralis from the chest wall and put the implant under. And then we had all kind of problem because of the pulling of the muscle. After radiation, the muscle would pull the implant upward. So now we move to a pre-pectoral. We don't touch the pectoralis muscle. We put the implant on top. But to do that, we need a larger piece of ADM, which is more expensive.
Yeah, so it's not because of the implant material.
Yeah. Thank you.
What is the length of time which you need after radiation treatment before you can perform the surgery?
Usually, as I said, now we try to do the surgery before radiation treatment. If we need to do surgery after radiation, usually I wait until the acute phase disappears. You know, the breast is red. And when it disappears 2 or 3 months, it's enough. We can operate. But the rate of complication is higher. No, much higher. More infection, more wound healing problems, more edema, seroma, everything.
So implant first and then
Yeah, that's the preferred way now.
And I have a question. Yeah, in that part with the radiation. If you put the implant before the radiotherapy treatment, which is the dose which can I give up on the implant? Because, for example, I know that the older type of implants can have at 30 degree gray of radiation, because after that they can be very rigid and they can break inside of the patient. How it's work with this type of
Well, actually, there is very little influence of radiation on the implant. The implant is made of silicone. It's non-organic. There's almost no problem. The problem is the tissue that covers the implant. When you give too much radiation to the tissue around the implant, then you start getting problem that we call it the implant problem. It's not implant. You take out the implant, it's as soft as the day it was born. But the problem is the tissue around. It becomes very rigid, and we call it capsular contracture. grade 4. Sometimes it comes along with painful breast, and we have then to remove the tissue. We just remove the tissue and bring autologic tissue from the abdomen, from the back, all places, just to remove the irradiated tissue.
Okay. Thank you very much.
You're welcome.
I would like to invite Lihu to felicit Kir Haim Kaplan.
Thank you.
Our next speaker is Hamdi Al-Shenawi.
Hear it?
Yeah, we already.
Good afternoon, everybody. I know we are late and we are exhausted. I will try just to shorten my presentation as possible as I can. I am graduated from Egypt, and I have a fellowship from American College of Surgeons, and as well as I'm a fellow of Royal College of Surgeons of Ireland. And also I have a high diploma in plastic and laparoscopic and endoscopic surgery from Strasbourg, France. Currently, I am working as assistant professor in Medical College, Arabian Gulf University in Bahrain. My presentation about is laterality in breast cancer still worth studying. It is a local experience in Bahrain. Simply, what we mean by laterality in general. We have a bird organ, like breast, as Dr. Haim was explaining for us, right and left breast. We have ear, right and left ear. We have two eyes. So laterality in general, it means preference of using one side over the other side. Like in football players, they use left foot than right foot. This is laterality in general. In breast cancer, we mean laterality, increased frequency of the left-sided breast cancer compared to the right side. And the global range is about 1.05 to 1.26. As all of you know, that breast cancer is the most common cancer among females worldwide. And the incidence, 1 in 8 females will be diagnosed with breast cancer in their lifetime. And breast cancer still the first top of cause of death by cancer in females. Yeah. In Bahrain, the latest statistics showed that breast cancer, it was in 2020, breast cancer was the most diagnosed cancer in Bahrain. Although we are a small island, small number of population, but it was high. It was about almost 38%. And close to Bahrain is Saudi Arabia, was also, was also breast cancer was the first. So laterality is well-known fact in breast cancer a long time. The first one who reported this phenomenon was the Swedish surgeon Filmberg in 1935. And till now, there is no clear explanation why this difference, left side more than right side. Theories just trying to explain why the left side breast cancer is compared to the right side, it's more than right side breast cancer. One of the theories suggested that the tissue mass in bird organs, like breast, is usually asymmetrical. And I'm sure Dr. Hain, he knows this better than us because he's a plastic surgeon. So there is usually some little bit difference between side and the other. And some people, according to this theories, they believe that the tissue mass, more tissue mass in the left side contributes to the left side or more left side breast cancer. Other studies showed also that the side of the breast cancer related to the dominant hand. And it was, there was one interesting study showed that among left-handed patients, they present with breast cancer 2 years earlier than normal persons. So based on this fact or this observation, they advised to start screening mammography earlier for those who have left hand or left-handed patients. The main aim of our study was to explore laterality of breast cancer in Bahrain as a model for Arabian galvanocanthus, as well as to explore the association between laterality and some of the clinical pathological factors, and of course, if any applied clinical value. It was a cross-sectional retrospective study, and we analyzed female breast cancer female patients who treated by us, and the patients were added consecutively to the study group. Exclusion criteria, we have excluded all non-Bahraini female breast cancer. And also we have excluded 3 patients with bilateral breast cancer and 2 patients with malignant phylloid tumors, breast phylloid tumors. So the remaining number of patients which we have studied was 223 patients. And we analyzed the laterality ratio for all, and we analyzed the association between tumor laterality and some of the clinical pathological factors. For example, age at diagnosis, nulliparity, history of breastfeeding, family history of cancer like breast, colon, ovarian, size of the tumor at presentation, tumor grade, tumor stage, hormonal status, HER2 status, estrogen, progesterone, multifocality, axillary lymph node status, positive or negative, and as well as 5-year survival rate. And we consider p-value less than 0.5 as a significant statistical. So the result of our studies, as I said, we have 223 patients. Out of 223 patients, left-sided breast cancer was 115, about 50.4%. And the right side breast cancer patients was 108. it's about 40%. And the laterality ratio was, in our study, was 1.06, which is close or almost similar to the global range. Then we have analyzed the laterality with all the clinical pathological factors. For example, laterality and age at diagnosis. We classify the patients according to age below 50 and equal or above 50. So we found that the laterality for the patients less than 50 years old was 0.97. And for patients above or equal to 50 was 1.19. Means if we look to this, its laterality increased with increasing age. Also, we analyzed laterality with positive family history of cancer, ovarian, uterine, colon. It was high in the right-sided patient. Right-side breast cancer was more higher with positive family history of cancer. And in overall, our studies showed the positive family history of cancer in our group of patients total was very high as well, was 33.6%. Tumor stage, again, laterality in relation to tumor stage. And our studies overall, tumor stage, majority of cases, 73% was early breast cancer. And early breast cancer was higher in the left-sided breast cancer than the right side. While the locally advanced stage and the distant metastatic stage was higher in the right side. So simply, majority of our cases were early breast cancer. Right side, more with the locally advanced and metastatic disease. Left side was, majority was early breast cancer. Age at diagnosis, again, right-sided patients was higher in age less than 50. Means simply right breast cancer, they present in our group of our patients at younger age. While left breast, it was, as our study doesn't show any difference between younger and older. Nulliparity, it was higher in, relatively higher in the right side breast cancer. Breastfeeding, of course, we are Arabs, they have, was high in majority of cases, 71%, almost 72%. And left breast cancer was higher as well. Pathology, yes, the most common pathology was invasive ductal carcinoma, and in both, and the right side breast cancer was associated more with non-specific type. HER2 receptors was HER2 status was positive and right side more than the left side. Multifocality, left side was higher. They present more with multifocal lesions than the right side. Lymph node status, it was 53.3% in overall cases, and the right side was higher than the left side. Again, tumor size and the left breast group of patient, tumor size was usually less or equal to 5 centimeters. It means they present at early stage. And the right side was advanced, more than 5 centimeters. 5-year survival rate in all stages, and it was good, it was 71%. And the left-sided was better than right side. Tumor recurrence, right-sided breast cancer, they had a local recurrence higher than the left side. And the left side had a relatively higher distant metastasis and in comparison to the right side. I don't want to go too much details. Just in general, till now, there is we don't have enough data regarding laterality in our area, in the Middle East, in our area, especially in the Gulf, Arabian Gulf. There is usually no more data about laterality, no studies till now. And so this is one of the issues make us encourage us to study to see what's going on. And in our area, there is a common demographic characteristics between Arab countries, especially in the Gulf. The Gulf countries, they have 6 Gulf countries, they have common demographic characteristics. Regarding breast cancer, usually breast cancer, they present at younger age and high percentage of positive family history, and as well as they present ratio of premenopausal is higher than postmenopausal. Yeah, this just summarize what I have mentioned. What's the difference between right-sided breast cancer and left-sided breast cancer? It is the same as I have mentioned earlier. And we have done review literature, extensive review literature. I am not going to go through all of this because there is no time, but just simply, sorry. Yeah, all studies showed the same results as ours. Higher percentage of early breast cancer in the left side. Higher percentage of advanced stage in the right side. Mechanism till now not known. All just people trying to explain. So it has been postulated that the right-handed patient, one of the interesting issue, right-handed patient, they can examine the left breast and axilla easily and accurately more than the right side. So this leads to early discover of the left-sided breast cancer at smaller age, at early stage or at smaller size. In our study also, ratio of positive family history was high in general, and it was almost 34%. And we trying to explain this maybe due to in our countries, in Gulf countries, they marriage close to close families or to close relatives more than maybe in Western countries. So positive family history was more in the right side breast cancers. And so regarding limitation of our studies, there was we missing of some demographic data due to retrospective nature of the study. We include only patients who operated by authors. So we ended by a small number of patients, 223 patients. But the good issue in Bahraini population is homogeneous, and this might reduce the resultant selection bias. In conclusion, our study was the first study regarding exploring the laterality in breast cancer among our undefined Arabian population. Laterality ratio in our study was 1.06, which is consistent with a global published range. And it was increasing with increasing age. Left-sided breast cancer were associated with higher positive family history, more locally advanced, and metastatic disease at presentation, as well as reduced 5-year survival rate. Also, right-sided breast cancer were associated with younger age at diagnosis, nulliparity, sorry, positive axillary lymph nodes, and HER2 was positive, more was right side. Local recurrence were more prevalent and the right side as well. Our study was published in the BMC, and this is our Bahrain, just a small island, very small island in the Gulf region. You are most welcome. I wish one day we'll invite you for a conference there. And thank you very much for any questions.
Thank you very much for your presentation. Is there any question?
I do have a question.
Yes.
Thank you for your presentation. What would be the answer for your title? Is it still worth it?
Yes,
Yes.
it is
Would you
obvious.
continue
It
to
is
study
obvious.
that?
There is a difference between right side breast cancer and left side breast cancer. The issue which I did, and I was just in rush, regarding the clinical pathological characteristics like HER2 status. It needs all this to be studied more. You need a large number of patients, and they need to be more studied to answer, to have the final answer. But for now, yes, it is. You see that there is a difference. Right-sided breast cancer, there is some difference than the left-sided.
Yeah, that was also my conclusion, but I wanted to make sure that I'm on the right path. Yeah.
Anybody do this research in Europe or in America about the laterality?
Yes, there are many, as I mentioned, that there are a lot of this, which I haven't go through it. I mentioned we have done extensive literature review, and our literature review was consistent with our results. This is a good thing. So, but in our area, there was some specific issue, like positive family history was very high. In comparison in Europe, Western, it wasn't high, like it was 34%. It's high. Yeah, because we are trying this maybe due to close marriage. Maybe Dr. Harim, I'm sure he's from our area also, and he knows the cultures and how the people there. So, honestly speaking, we have done extensive literature review. If you go through it in detail, it's there, and it has been published in BMC. So it is there. You can go through it and yes.
Okay. Thank you very much. Now we will have now I want to invite Corinne Chavez to felicit Thank you very much. Yeah, now we will have a short break of 15-20 minutes approximately. We have coffee there.
I will miss start today.
Okay, for me it's fine.
Yeah.
We are not at the school, so you can leave when you want.
Yeah, yeah,
Yeah,
yeah. I got this pitch at one startup conference.
okay. Okay. So we will continue now. I invite Corinne Chavez to see her presentation. Please share the screen.
I think it's sharing. Okay, good afternoon for the ones who are here and the ones that are like, for my presentation, I would like to guide you through the development of preclinical analysis of antimitotic products targeting CYP1A1 expressing breast cancer cells, exhibiting improved rodent liver stability. In fact, I would like to start with some breast cancer statistics, and I would like to mention why the study of breast cancer and breast cancer therapies is still important, even though many therapies are already available for breast cancer treatment. We have breast cancer as the most common cancer worldwide in 2020, and in Canada, where I work, we also have the same trend as worldwide percentages. So we have breast cancer in Canada as the most common cancer in female and the most common cancer in general. So it is very important to treat cancers that are refractory to current treatments and that represent like a challenge for physicians for treatment. So as we already know, there are many treatments for breast cancer, such as surgery and resection, which is like one of the first options according to the size and location of the tumors. We have radiotherapy and all the related technologies, such as brachytherapy for cancer treatment. But again, not all the patients are good candidates for those kinds of treatments. We also have immune-related therapies, hormone-based therapies, and classic chemotherapies, but all of them can cause possible side effects, such as the one that we already know for common chemotherapy, which is like, for instance, the most common lung toxicity, alopecia, like, I mean, the common side effects of breast cancer. We also have other technologies that are like novel for cancer treatment, which, for example, are targeted therapies. I would like to focus now on targeted therapies. Targeted therapies could be two types, which are monoclonal antibodies or small molecules. And I will focus a little bit more on small molecules, which are usually molecules with a molecular weight of 900 grams per mole, and ideally 500 according to Lipinski's laws. They are easy modifiable structures and they target a particular molecular mechanism. So I'm going to now give you an example of a molecular mechanism that can be targeted for the development of targeted therapies. The one that I'm going to be talking about is CYP1A1, which is an enzyme that usually detoxifies potentially carcinogenic xenobiotics from the organism, and it is expressed in several breast cancer tumors. But the thing that is important to note here is that CYP1A1 has a low expression in other tissues, such as healthy breast tissues and, in general, healthy tissues. It has also an important role in conversion of products, and so we can use it for CYP1A1 targeting therapies. Currently, there are many products that are used as a target for CYP1A1, such as the ones we see here, and they are known to be biotransformed inside the body into alkylating agents. The problem is that alkylating agents show toxicity and low selectivity towards healthy cells. So they are going to damage cancer cells but damage also healthy cells. And what did we do in our laboratory to create a novel CYP1A1 targeting therapy that will not affect as much healthy tissues as the other already existing products? Is that we developed a chemo library of several drugs, which are called PEPSOS, according to the acronym in French, that were biotransformed only in tissues that expressed CYP1A1. It is important to say that there could be also a little effect over healthy cells, but it is significantly less than other therapies that are not targeted therapies. Several years ago, we selected from this chemo library one compound that was our hit compound, and it was selected as the most promising PEPSO of this first generation of PEPSOs. It was highly active towards cells that expressed CYP1A1 at 40 and 72 hours of exposure. So we thought that we had hit something really good, and that we could develop it until maybe clinical trials. Then, after the selection, we decided to continue the development because, of course, these results are preclinical and in vitro. So, before continuing with the development of PEPSOS, I would like to mention the generalities of the mechanism of action of PEPSOS. They are biotransformed into antimitotic compounds, activated, as I already mentioned, by CYP1A1 in CYP1A1 expressing cells, and they exhibit antiproliferative activity in vitro in the nanomolar range. Finally, they arrest the cell cycle at the G2M phase. So those are the general characteristics of antimitotic compounds that were exhibited for PEPSOS. So they fit into the category of antimitotic drugs for cancer treatment. So as I mentioned before, we selected PEPSO CU818 and its counterpart 602. Its counterpart is the one that was already transformed into the antimitotic drug. 818 is the product, 602 is the active compound, but the same drug. So we asked ourselves, how can we test our compounds to make sure that it is a good potential treatment? We decided to radio label them and follow them in vivo, in mice, and we decided to administer our compounds to healthy and also to tumor-bearing mice. As we can see here, the biodistribution was mainly in liver and kidneys, and a little bit in lungs also. And it hit a peak of biodistribution at 1 hour. Finally, for the evaluation part, the in vivo evaluation part, we saw that at 24 hours, we didn't have any more drug in the system. We thought that we had hit something that was going to change our vision of targeted therapies targeting CYP1A1, but we had a problem. Our problem was that the compound was not staying in the animal system for enough time in order to have an effect over the tumor. So we thought about other responses for modifying the characteristics of the compound that is not working because of its biodistribution and clearance. So we decided to make a synthesis of other compounds with longer alkyl chains. So we chose pentyl, hexyl, and octyl chains. The ones that I mentioned before were only 3 or 4 carbon compounds. So we decided to make longer alkyl chains in order to see if they were more resistant to clearance and biotransformation. We made a synthesis, we validated that we had the good structures. Once it was validated, we tested our compounds, and in fact, we found that they were highly active. Those are pentyl-bearing compounds. And as you can see here, the ones in orange are low soluble, but they are highly active. And the ones in blue are highly active and they had also a good solubility for further experiments. So the blue ones are the ones that we're selecting for further analysis. Then for axial compounds and octyl compounds, as we can see, they were too long. They had other problems. So even if they showed small activities, we did not select them for further analysis. We analyzed them in vitro for their half-lives in human mice and rat microsomes. And in fact, we had hit something interesting. By elongating the chain with longer chains, we had better half-lives. So it means that they stayed longer intact before biotransforming into the compounds that are rapidly cleared from the system. We validated that they belonged to the same category of antimicrobial compounds. So as you can see here, they are all in the category as they disrupt microtubules and they induce the rest of the cell cycle in G2M phase. So they have the same characteristics that I mentioned before that belong to antimitotic drugs. And finally, we made a final selection based on the activity and their solubility for further tests. So from the list that I mentioned before, we selected only 2 compounds that were the best that we had. We validated, after validating the target of Pepsos, we performed an antitumoral activity test. So at the right side, we have the biotransformation by CYP1A1. As you can see here, we confirmed that those molecules are biotransformed mainly by this enzyme. So that's a check. We validated that our target is good. And finally, we used modified cells that expressed CYP1A1 and that did not express CYP1A1 to perform a xenographed model in eggs with both compounds that we selected. And as we expected, we are active towards CYP1A1 expressing cells, and we are not active towards wild type cells that do not express CYP1A1. So it was a success. My conclusions are that the first compound that we selected, even if it was a very promising compound, the biodistribution was very limiting for the development of the technology, and it was rapidly eliminated from both healthy and xenographed mice. So it was not suitable for further evaluation. Then, as we modified the alkyl chain, we obtained pentyl, axial, and N-octyl bearing compounds. After analyzing those compounds, we concluded that pentyl bearing compounds were the most suitable for further analysis. They had a good antiproliferative activity, longer half-lives, and a good antitumoral activity. And finally, we hope to develop further those compounds that are very promising for the treatment of breast cancer that expresses this particular enzyme. I would like to thank the funding that we received from the Canadian institutes and associations, and also my director and the group of the research group. So thank you for your attention.
Thank you very much for your presentation.
You can give me the certificate.
And yeah.
I would like to
yeah.
someone photo. Sorry, sir.
No problem. Yeah.
Yeah.
Yeah, it was published. Yeah, yeah. It was recently published. In fact, that's the second part of the research that we performed. We had a chem library of thousands of compounds.
How do you know how you got
Sure.
It doesn't matter, just have me.
And has love work.
But again, you have your family.
No.
It is.
Sorry,
Many
excuse me.
to carry on many things. So many is that this is makes sense to do both tests.
Yes.
But another way, I had problem 8 years ago. Where also, but everything is fine. But I was really stressed a lot, I have to say. And I was thinking, how is this working? That nothing will show up late last moment in the screen and the mammography, and later show up so fast.
Because sometimes the development in the first stages is slow, and then something triggers the development.
And blood sample
No.
just clear up everything.
Yeah.
So I.
Exactly. So,
Okay. Thank you for this interesting talk. Yeah, yeah. I was honest.
You'll see after.
Yeah. And now we can go to the next speaker, Vincent Oulet.
All right. So, like you said, my name is Vincent. I'm a PhD student in the research group of Dr. Sébastien Fortin. So we're located in Quebec, Canada. So the French-speaking part of Canada. Basically, so it's going to be a bit of a continuation of the previous presentation from Corinne. So we'll see it's a variation of the PEPSO that she presented. So it's a slightly different structure, but it's basically drugs that have the same mechanism of action. And the novelty with this class of compound is that we are trying to synthesize salts, because one of the major drawbacks with the molecules is that they have low solubility. And when you want to do some studies, well, it limits your concentration of drugs that can have an effect on cancer. So we tried to synthesize salts to enhance their solubility. So first and foremost, I'm going to just do a brief introduction. I know many spoke of it, but just remind everyone. So breast cancer, as you all know, is a major public health concern. It's the most diagnosed type of cancer in women worldwide, even in Canada and lots of countries. It's about 25% of all cancer cases. And in the latest statistics from GloboCan in 2020, there were more than 2.3 million cases diagnosed. So it's really a big issue. And out of that, it's about 700,000 deaths. So we can clearly see, even there, if the overall survival rate is 90% after 5 years, quite good. It drops significantly when you have a low distant stages. So there needs to be improvement done to cancer drugs, especially because we have drug resistance, lack of efficacy, and major side effects. So there's still a need to try to improve drugs that are used currently as a treatment. So we try to address this. So before going into the molecules, I just want to introduce some key targets that are used for cancer treatment, especially microtubules in our case of interest. Briefly, they are important cytoskeleton components, and they have major roles in the mitotic function, such as cell signaling, mitosis, transportation. So if you try to destabilize these compounds, well, they have a direct effect on the mitosis of cells, and consequently, that can lead to the cell's death. So in case of cancer treatment, is a good thing. So like I said, they play a pivotal role in the formation of the mitotic spindle in the mitosis. So they are a key interest for cancer drugs. Another target that is quite interesting is cytochrome P4/500, which are responsible for the biotransformation of about 75% of marketed drugs. So certain isoform, like Corinne talked about, CYP1A1 is overexpressed in a variety of solid cancer tumors, such as breast cancer, and without being present in surrounding tissues. So we can use that to target our effects of our drugs. So in this case would be CYP1A1, and have an interesting use in personalized medicine to try to develop new drugs to have less effects, side effects, the main drawbacks of conventional therapies that are currently used. So that's brings us to our molecules. So we synthesize which we call bio isomers of PEPSO, which we call PEPSA. So they are a family of potent prodrugs of anti-cancer agents. So they exhibit high anti-proliferative activity and selectivity on breast cancer cells that express CYP1A1. They disrupt the microtubule network, like I talked before, and they arrest the cell cycle in the G2M phase. The main thing here is that they are bioactivated by, does it work?
Yeah, there we go. Okay, so we have the drug here, and we have an alkyl chain here, and with the action of the enzyme CYP1A1, we have a dealkylation. So the alkyl chain is removed, and we get this compound here, which is called PIPSA, which is our active moiety. So this is the drug that has an effect on cancer cells. So it needs to be bioactivated to have this effect. So, like I talked a bit at the beginning, major drawback of our molecules is that they have poor solubility in aqueous solution. So that limits their concentration that can be used in animal studies. So a solution to try to overcome this step is to use salt formation, which is a widely used strategy to improve the solubility of drugs. About 50% of drugs on the market are sold as salts. So it's a really useful solution to try to enhance this property. So basically what is a pharmaceutical salt is that you have here in blue is your API, which is your active pharmaceutical ingredient. And when you have your molecule, which has what we call an ionizable function, so it can react with either an acid or a base and form a stable salt. So that's what we're going to do with our molecules. So basically here, I'm going to show you a bit of drugs that are available on the market as salt. So here we have vinblastine, vincristine, which are marketed as a sulfate salt. So I put the nitrogen here is the basic function, and here in red is the acid function. So this is formed as a salt. And we also have here CA4-phosphate disodium. So we have the salt as a sodium salt. This is currently used in the clinical trials. So the hypothesis what we have is that we will be able to increase their solubility by forming their salt and without altering their activity and their selectivity on cancer cells. So the objective of the study was to design and synthesize these new salts and afterwards evaluate their aqueous solubility. And afterwards, we're going to evaluate their mechanism of action and to see that they retain the same activity as their neutral counterparts. So here, I'm just going to briefly show you the synthesis. I'm not going to go into details, just to see that you understand how we make those molecules. So I'm a chemist, so I synthesize those drugs. So we start with this compound here, and first step is to add the alkyl chain. So here is R, so it's represented, it's either a butyl chain, which is 4 carbons, or a pentyl chain, which is 5 carbons. Afterwards, we're going to do what we call a chlorosulfonation. So we're going to add this compound here. We're going to treat it with acid, so that afterwards we can react this compound here with a aniline, which will give our main product, which is like this is the drugs that we already synthesized, but they're not salt. So what we do afterwards here, which is called a sulfonamide function here, is slightly acidic. So we react this compound with several bases, such as sodium hydroxide, third butoxyl potassium, and butyllithium to make salts. So we have either sodium, potassium, or lithium, and we have good yields from 70 to 80, 90, 97%. So now what we have synthesized those compounds, and of course these compounds were characterized using NMR mass spectrometer, so to make sure that we have the proper structure. So the first thing that we did, well, when you have new compounds, you do a screening on different cancer cells line. So basically here, what we did is we did MCF-7 and MDA-MBA468, which are expressing CYP1A1. So because as you remember, we need to activate the drug so that they have the effect. So we evaluate them on cells that express the enzyme. And on the contrary, MDA-MBA231 does not express CYP1A1. And as you can see in the result, here we have an activity of about 30 nanomolar, but here it's higher than 25 micrometers. So it doesn't have an effect on those cells because it doesn't express, or its expression of CYP1A1 is lower than the MCF-7, so it doesn't have the same effect. And also we evaluated them on ACAT cells, which are keratinocyte LT cells, just to see if we have toxicity with the molecule on other cell line. So, and also we evaluated the hydrosolubility, and we can clearly see that we increase substantially their aqueous solubility. We have between 4 and 9 micromilligram per milliliters. So if we do a quick highlights of what we found out is that compound 1, 2, 3 10, 11, and 12 are the most potent ones, and they are about 30 to 50 nanomolars, which is quite good. And when we look at the selectivity ratio compared to cells expressing CYP1A1 and not expressing, we have really high selectivity ratio. So we see that this drug has an effect with CYP1A1. Afterwards, we took the most potent one, the sixth one that I just showed you before, and we did the analysis to evaluate their mechanism of action. So what we did first is we evaluated their on how they affect the cell cycle progression. So we analyze them, and we see that all drugs arrest the cell cycle in the G2M phase, which is the phase where the mitosis is happening. So we clearly see that we have an effect on mitosis, which potentially leads the cell to its apoptosis. And we can see here from 203 and molecule 19 are like controls, and we see that they have the same effect as the neutral counterparts. Afterwards, we evaluated their ability to disrupt the microtubule dynamics. So we analyzed that by immunofluorescence. We can clearly see that here we have the MSO, which are our negative control, which is just like the normal cells. And we can see that we have a good network of microtubules. But when we look at 1, 2, 3, and 10, 11, 12, we see that it has irregularities around the network. It's nonlinear, it's irregular, it's concentrated around the nucleus, or even has some fragmentation. So we see that we have an effect on on the cells, on the microtubules. And finally, what we did afterwards is that we looked at the bioactivation of our drugs. As you remember, it needs CYP1A1 to be activated into its potent antimitotic drug, which is CAU639. Here you can see it. So we evaluated that with microsome of CYP1A1, and we analyzed that by liquid chromatography, so our performance liquid chromatography. So here, I synthesized this drug so that we have an external standard. So we see the peak here for this compound, the active drug, and this is the peak of the prodrug. So you see at 0 minutes, we have only the prodrug, but afterwards, we did 30 minutes, 60 minutes, and 2 hours, and you can clearly see as time goes up, the concentration of the product diminishes and the concentration of the active moiety increases. So here you see after 2 hours, we have like a 27 increase compared to 0. So we can clearly see that this drug is being bioactivated by the enzyme. And since we synthesize the control, we'll see that it's clearly that compound with the retention time here, we can clearly see that it's the compound. So we see that it's in a time-dependent manner that we activate the drug. So if I do a brief summary of what I just showed you, so we synthesized 18 new salts of PepCell's drugs, and we evaluated their hydrosolubility and biological properties. First thing that to show is that the salts are clearly more soluble in aqueous solution. So that's the main thing that we wanted to do, and we achieved it. Afterwards, they maintain the same selective and interproliferative activity on CYP1A1 expressing breast cancer cells. They arrest the cell cycle progression in the G2M phase. They disrupt the microtubule, and they are being bioactivated by CYP1A1 microsome to its potent drug. So overall, they retain the same activity and biological properties as their neutral counterparts. So that this being done with the salt, we can allow for better formulation and increase the drug concentration in further biopharmaceutical studies or animal studies. So here I would just like to mention a few people, especially my supervisor, Sébastien Fortin, the research group, and also the funding, different partnership but funding by the full government funded organization, and also studentship that I received for my thesis, my PhD studies. And I would like also to thank René Godot, which our collaborator of the group, who reviewed this work. And well, thank you very much for your time. And if you have any question, you can ask them.
Go back to the
Wait.
That those are the fingerprints.
Yeah, you were asking before. Yeah.
So the bottom two slides.
Yes.
Or the last three.
Yeah.
What are the extra peaks between the two?
That could either be because yes, we have CYP1A1, but it acts on the drug, but it can also act on different parts of the molecule. So you can have smaller fragments. But basically what we want to look at is this one is being formed because that's our active moiety. But
In fact, we have a theory there for the OH.
yes, oh yeah, okay. So because first you have your drug, but to get to this active one, it can go to different steps. So it's being metabolized in different ways. So here it's the hypothesis, but we will need to confirm with mass spectrometry, but it could be an intermediate between the prodrug and the final active moiety. So it goes through a different process being metabolized in steps. So that's what you can see the different peaks there. Yeah, exactly. Yeah, you can see like that. Yeah. Yes, yes. An hypothesis is that the chain here it's for.
So it's almost like a combination.
Yes, because here you have your alkyl chain here, but it could be cut like it's 4. So it could be after 3, 2, 1, and then it's get dealkylated. Yeah.
And people with allergies to sulfites, would they have an issue with the salts here?
It's approved to be used in salt formation, but yes, some people can have allergies.
Yeah.
So that depends on the doctor afterwards to see the patient, the diagnosis, to see if it has a condition, and maybe use another formulation or different. Yeah.
But he has 2 versions. Of
Yeah.
that.
That's why yes.
And,
Yeah, we have sodium, potassium.
That's right.
Yeah,
Yes.
So they would formulate something.
Yeah,
Yes,
for a
the
patient.
same
exactly.
drug, different.
Because
combination.
what studies show is that if you have a different counter ion, it can have a different effect also. So that's why we synthesize the few.
So do you think medicine is going to go along the lines of treating the patient as an individual, not as a group of people having a condition?
Well, doctors now tend to like with gene with mutations. They try to like isolate the patient to have a better specified treatment, but it's quite expensive. So yes, we need some like an overall drug that could treat like lots of people. But also now we're trying to try to personalize it to have a better outcome at the end that could evenly save the patient in the end.
Yeah.
So it's an equilibrium. Yeah.
That'd help with a lot of.
Yes.
a lot of types of
Yes, exactly. Yeah.
conditions, wouldn't it?
Yes.
It's
Yeah.
always about money.
Yeah. Because to make personalized treatment, it's quite expensive because you need different
That's right.
form of the drug.
Research money.
Yeah.
We received 1 million for the development of our project.
Yeah. Yeah.
Yeah, from Canadian government.
Yeah.
Wow.
So we're trying to
for
expand that,
our
try to
project.
optimize the formulation, the structure. Yeah. So salt strategy is one of the strategy, but you can use liposome, you can use nanoparticles, because salt formation does not always work, but in case it does, but it's one of the solutions that can try to. Yeah.
Well done.
Mm.
So the guys are down.
Yeah.
Thank you very much,
You're welcome.
Vincent.
Thank you.
I want to give you this certificate of
Yes.
appreciation.
Yeah.
Retourne à la diapo, il y a Sébastien.
Oui.
Thank you very much. Okay.
Yeah, very good.
Yeah.
I'm Spanish because I'm my friends
Sorry, guys.
It's a shame I didn't present.
We have one more presentation.
Or this week, actually.
Yeah, we have one more presentation that will be online because Sadie Eliso, she's not able to attend, or he. Is she? Okay, she. Yeah, she. Okay, so I would like to ask her to share her screen. Sadie, can you hear us? Okay. Sadie Eliso. French keyboard. Okay.
Hello, everyone. Are you able to see me and hear me okay?
Yes, we can hear you and we can see your screen.
Fantastic. Thank you so much. Let me know if it's all right to begin.
Yeah, you can start anytime.
Okay, fantastic. Well, thank you everyone who's here today. I certainly appreciate you joining. Appreciate everyone's time and attention and participation. My name is Dr. Sadie Eliseo. I'm a primary care physician and I work in Boston, Massachusetts in the United States at the VA hospital, which is the Veterans Affairs Hospital. It's a hospital for U.S. military veterans, and it's our nation's largest integrated healthcare system. I am a clinical instructor of medicine at Harvard, as well as an adjunct instructor at Boston University, and I am a subject matter expert in a field called trauma-informed care. And I have the honor of being able to speak with you today about trauma-informed care. Our objectives are to define trauma and trauma-informed care, which I will abbreviate TIC. Number 2 is to understand key principles of conducting a medical visit in a manner that's sensitive to everybody, but particularly those who have a history of trauma. And finally, to review examples of trauma-informed language and behaviors that you can use before, during, and after your physical assessment. Whenever you go in, you're going to check vital signs or you're going to touch the patient. How can we be trauma-informed? So a brief advisory: if any portion of what we discussed today makes you uncomfortable, please take care of yourself in whatever way suits you best. You can leave the meeting, get up and stretch, grab a glass of water, whatever is comfortable for you. So I'd like to begin by defining trauma. It is a very heavy subject and can be misunderstood. There are many definitions of trauma. I like this one from SAMHSA. It's the Substance Abuse Mental Health Services Administration. And these are their 3 E's. So trauma can be any event that is experienced as harmful and has lasting adverse effects on our function or well-being. So you can imagine that's a pretty broad definition. It can encompass many things. This is a visual that shows you that there are so many experiences that have the potential to be perceived as deeply stressful, from the individual all the way up to the societal levels. And here are some examples on the left and right. We see that there is discrimination, like sexism and racism. We have violence and abuse, including intimate partner violence and gun violence, transgenerational trauma like slavery and war, natural disasters, including pandemics, medical trauma like the things we attend to every day in a healthcare system, including physical trauma like motor vehicle collisions, and then issues related to the social determinants of health, like housing and food insecurity. So you'll see by scanning this list that these are not unique or extraordinary circumstances the way we initially envisioned or conceptualized trauma to be. These are very common, very human experiences, which is important to recognize because it's not only our patients that experience these events. This is common to all human lives. And so healthcare trainees, nurses, physicians, administrators, leaders, we all have the potential to be exposed to this, not only in our own lives, but to be witness to these in others. And we call this secondary trauma. So it's a tough life. It's important to understand adverse childhood experiences, also known as ACEs, if we're talking about trauma today. So back in the 1990s here in the United States, there was a survey of thousands of Americans that asked them whether they had adverse childhood experiences before the age of 18 in these categories: abuse, neglect, and household dysfunction. And what they found was that over half of the respondents to the questionnaire endorsed at least one ACE. And we have found through other studies that if we expand ACEs to include exposures to community violence, racism, things like that, this number is even greater. We know also that healthcare professionals, including nurses, have rates of ACEs that are comparable to the rates of the general population. So this is not, again, something that is outside of healthcare employees. This is everyone's experience. Fast forwarding, we know that individuals who have more ACEs, 6 or more ACEs, live 20 years, can die 20 years earlier on average compared to those who have no ACEs. Now, ACEs are not as predictive of lifespan on an individual level, but it's really important to note this. And here is something that we call an ACE pyramid, and I'll review the different tiers with you. Starting from the bottom, we have trauma, and then that's impacted by our social conditions in which we live and work. On top of that is ACEs, which disrupt the development of the brain, especially in early life, which can lead to social, emotional, and cognitive impairment. Then we may adopt some risky health behaviors to cope with that toxic stress, for example, substance use. And all of that can lead to disease, disability, and early death. We know from many, many studies that toxic stress levels in the body can activate hormones in the brain that actually lead to inflammation in the body. And they alter our metabolism, they can impair our immunity. And so all of this leads to morbidity and mortality. So this is very difficult to think about. It's hard to wrap our minds around this impact. And I want to know, what can I do about this? How can we help? And for me, that answer lies in trauma-informed care. Trauma-informed care is a framework for supporting people who have experienced trauma. And importantly, we can apply these principles universally across all clinical encounters to help build resilience for our patients and for ourselves. Importantly, that it emphasizes safety and empowerment, and we heal through each other. We heal through relationships, specifically safe, collaborative, and trusting relationships. I first learned about trauma-informed care from a medical student, actually. I noticed that when I was examining my patients, they were visibly uncomfortable at some of the standard maneuvers that I was performing. And so I started adjusting how I spoke and where I stood in an effort to make my patients more comfortable. And a medical student took note of this, and she asked me to tell her more about my trauma-informed approach. I had never heard of that before. And when she told me what it was, I was completely amazed. And I designed a formal framework for a trauma-informed physical exam, which I will be sharing with you today. That framework has since been published and studied. We won an award for it, and it is now being taught at medical schools across the United States as the new standard method of examining patients. So it's a joy for me to be able to share with you an abbreviated framework of that work today. As we think about any trauma-informed program, these are the 4 R's also from SAMHSA that we try to adhere to. Number 1, we aim to realize the widespread impact of trauma. Number 2, we aim to recognize the signs and symptoms. 3 is to respond by putting trauma-informed measures into practice. And finally, resist re-traumatization. What is re-traumatization? I remember one time swinging my stethoscope off my neck to start listening to the patient's heart, and the patient jumped. I had basically swung a rope at his neck, and that caused an immediate reaction that made his body feel that he was in danger. So with a physical assessment, especially, it's important to avoid re-traumatization. As we think about how to approach patients when we're speaking with them or when we're examining their bodies, when we're counseling them about what happens next. These are the 6 principles of trauma-informed care, also from SAMHSA, that we can think about applying. So number 1 is safety. That is physical, psychological, and emotional safety. Number 2 is trustworthiness and transparency. It's important to maintain transparent operations in your healthcare system to build and maintain trust. Number 3 is peer support, where trauma survivors connect with one another to gain and inspire hope. 4 is collaboration and mutuality. There's this recognition that we should have a leveling of power differences in the healthcare system and a sharing of power as we make decisions. And 5 is empowerment, voice, and choice. We build on people's strengths rather than their weaknesses, and everybody has a seat at the table. We all have a role to play in a trauma-informed approach. And 6 is attending to cultural, historical, and gender issues, where we recognize that trauma has been passed down in certain populations through history. So we aim to acknowledge that, move past biases, and move towards healing together. So now I'll share with you this abbreviated framework I have for trauma-informed physical exam. In many cases in the nursing world, this is called a physical assessment. It's basically what we do using our hands, our ears, our eyes, our stethoscopes to figure out what is wrong with the patient and how we can help. So there are 3 sections: before, during, and after the exam. We'll begin with before the exam. Number 1, we make sure that our nonverbal skills are as they should be. We sit or stand at eye level with the patient. We're not standing over them like this. We have appropriate eye contact, no loud noises or sudden movements. Keep your hands out of your pockets so it's always clear to the patient what you will be doing with your hands. Next is to set an agenda for the visit, explain the things that you are going to carry out. For example, we're going to be checking your blood pressure and heart rate. Next is to make it standard. This is something we do for all patients who come in for their office visit. It's not something that is being done uniquely for that person. You can then identify what, if any, concerns they have before you begin, and ask what you can do to make them more comfortable. And finally, offer a chaperone, which is sometimes appropriate both in the outpatient and inpatient setting. For example, historically in the United States, it has been required by institutions to offer a medical chaperone only for a woman patient if she undergoes a breast, genital, or rectal exam. But the majority of my patients have always been male, and they're the ones who have taught me the impact of sexual violence. So this is just a call to think more broadly about who might benefit from a chaperone and even a support person in the room that the patient identifies, a support person or a loved one might be appropriate. Please recognize that these strategies are simply suggestions. These are neither standardized nor validated nor required, nor do they go in a checklist sequential order. So these are tips that you can experiment with. There is an excellent question in the chat. Do we have a procedure for those patients with hearing loss? The majority of my patients struggle with hearing, as I take care of predominantly an older male population in their late 70s and 80s. Many of them have ringing in the ears from the use of explosive devices and guns, etc., and loud machines. I think for hearing loss, it is particularly relevant to slow down, make appropriate eye contact, use sometimes exaggerated mouth movements for individuals who prefer some lip reading. And you can turn the screen towards the patient if you're using a computer to type out your instructions, point to what you're looking at. And I always have a large pad of paper next to me to write in very large font all of my suggestions. Most facilities are equipped with some translator services, including sign language for people to use if that's necessary. And one of the key principles of trauma-informed care is to make sure that care is engaging to the patient, that they are true collaborators, that this is a meeting of two experts. So if you're not able to provide them a means of communication that is interpretable to them, then that's not trauma-informed. A clear mask, I do like that idea. All of these suggestions in the chat are brilliant. Portable hearing loops, voice-to-text apps, fantastic suggestions. So transitioning to during the exam, we attend to draping, making sure that the patient is comfortable at all times as best that we can. I'll give you specific examples for that. We do recommend privacy when the patient is dressing and redressing. You can use the curtain and or the door to allow that for them. I like to refer to the gown as what the patient wears and the drape as that sheet that goes over their lap. It's important for the patient to be empowered to move their own gown, drape, or clothing when possible. It's theirs to move and touch. It's not yours. If the patient does need help, you can offer to provide help. Don't assume that all patients who identify as male are comfortable bearing a full chest and taking all their clothes off, right? We can offer them a gown or drape if they would prefer. Allow patients to wear clothing on body parts that are not being examined. So if a patient has a pain in their ankle, they don't have to take their pants off. They can just roll up the pant leg. If a patient has a mole that they want you to check on the lower back, they don't necessarily have to take off all of their clothing. Perhaps they can lift up the shirt so that you can see that spot. Also, I recommend knocking before re-entering a room and ensure that the patient says something like, "Yep, come in," before you open the door. Even though it's an exam room that you use that's in your hospital building, now it's the patient's room. Moving forward in this framework, introduce the exam components that you're going to perform and explain why they're being done. They're being done for medical reasons, not just because, or not because you want to touch the patient's body, not for fun. It's medical reasons. Ask permission before touching the patient, particularly in sensitive areas. Stay within their eyesight while also respecting personal space. I'll show you a couple pictures of that. In the first photo, I want to listen to the patient's lungs. And we often do this by standing behind the patient because the lungs are on the back. That's how we listen with the stethoscope. But the patient can't see where I am or what I'm doing. So this can be a little unsettling for the patient. Instead, if I stand at her side, I'm within her peripheral vision. The stethoscope still reaches. It's long enough. I still get the data that I need, but I'm creating a psychologically safer experience for the patient. In this photograph, I'm showing that when the patient is completely 100% supine and lying flat, this is a subordinate position that can activate memories of prior abuse. And so if you raise the exam table a little bit, maybe 15 degrees, 20 degrees, maybe she's a little high in this photo, and you can also offer them a mirror for the things that they can't see, this can be more empowering. There's also a movement towards self-insertion of the speculum for a speculum exam if you're doing a pelvic exam, self-insertion of swabs for a non-speculum exam, self-insertion of an ultrasound probe for a transvaginal ultrasound. And even the patient can check their own stool test for blood rather than the examiner using their own digit to insert their finger into the rectum. Respecting personal space. Here in this photo, I'm listening to the patient's heart. I'm pressing up against her knees. I'm right in front of her face. This is a little awkward, so I can still stand at the patient's side the way that I did when I was listening to her lungs. In the first photograph, I'm checking the patient's heart rate, but my hand is very close to her groin, to her genitals. So instead, the patient can be asked to extend her wrist to rest on her knee, or it can rest next to her on the exam table. I'm checking blood pressure here, and in the first photograph, I'm pressed up against the patient's knees. She's leaning to the side. She's trying to support her own arm. It's a little bit awkward. In the second photograph, I'm standing outside of her personal space. She's able to rest comfortably, breathe freely, and I'm supporting her arm. And in this photograph, I'm suggesting that we should avoid blocking the exit door for patients so that there's always a perceived ability to escape. Not that our patients regularly need to escape, but the brain needs to perceive an ability to exit. It's okay if you're standing here for 2 seconds to say something, but for a prolonged conversation, we recommend sitting at eye level and not blocking the exit door. Next, we use simple clinical language. I'll explain what that means. Trauma-informed language should be easy to understand. We definitely try to avoid medical jargon. Instead of saying that you're going to auscultate the lungs, you can say listen. Instead of palpate the abdomen, press. Be cautious with the imagery that you provide to patients because you never know what's going to be upsetting or triggering to them. I remember a medical student found that the patient's blood pressure was high and he wanted to repeat the blood pressure, but to relax the patient. So he said, just pretend you're at the beach. But then I remember reading the mental health note for another patient that said, it quoted the patient as saying, my family's going to the beach this summer. I can't go with them. Anytime I'm at a beach, all I see are dead bodies. So we really cannot make an assumption about where someone's past negative experience has been or the circumstances. So just avoid providing imagery. Also, at all costs, always avoid any possible sexual connotation. We aim to minimize the power differential that already exists between the clinician and the patient. They're already coming into this healthcare visit in a vulnerable position, expecting to be asked personal questions, touched by a stranger, and they're wondering what terrible things they're going to find out about their health. We aim to accommodate patients who speak other languages and or who have any disabilities. And the word choice should be professional rather than personal. I'll show you some examples of that. So the first word that may be surprising and not trauma-informed is the word your. I like to use the word the when referring to body parts during the exam. For example, it feels very different to hear, now I want to look at your penis, versus I will now inspect the penis. The means that it's an anatomic body part I'm going to examine. Just like I've examined hundreds of body parts, just like that. It's less personal and zoomed in on the patient's body. It's a little more detached. And then rather than saying butt, which is a casual term for buttocks, we can use other phrases, including bottom or buttocks. And the words bed and sheets frame the exam in an unwanted, intimate manner. So this is an exam table with a drape. It's a medical visit. Rather than saying things look normal, this is particularly relevant for exams of reproductive organs. We want to be inclusive of all shapes, size, appearances, and identities, so we can say that things appear healthy. Instead of asking the patient to put their feet in the stirrups, that's a common phrase we use here. Stirrups can resemble a restraint, and so foot rests is a more appealing, soothing term. And instead of saying, that looks good, maybe that looks healthy. Instead of saying that I want to do this to you, I'm going to look at you and feel you and touch your body. Perhaps I'm going to do this, or would it be okay if I did this? I'm going to inspect or check or examine or evaluate. I already gave you this example of just pretend you're at the beach where I'm providing imagery to the patient. Instead, you could say, some find it helpful to take a deep, relaxing breath. Let's try in through the nose and out through the mouth. And so you can model that and do that with patients. That's an example of a grounding exercise where we help to calm down the brain, interrupt that threat response, and get us into a state of calm and presence. And finally, in terms of trauma-informed language, I recommend that we all avoid the phrase "for me." I hear this phrase constantly in the United States as we give instructions to patients about what to do next. For example, roll up your sleeve for me. That phrase "for me" can sometimes enhance that power differential that exists between patient and examiner, and it can also sometimes be sexually suggestive and inappropriate. Take off your shirt for me. Hop on the bed for me, swallow for me, bend over for me. These are common things that we say during the physical exam, but it's just not necessary. So you can ask the patient, can you roll up your sleeve so that we can check your blood pressure? Most of the time, the patient will be able to do so on their own, but if you feel they need assistance, you can offer that. Next, you can check in with the patient periodically and as needed, just by asking, hey, how you doing? Use professional touch. I'll give you some examples of that. I do place a firm touch on the patient's shoulder when I'm reaching behind them, like if I need to grab the otoscope or a tissue or something, so that they still know where I am in the room. And I do that also when I'm listening to the back of their chest for the lungs, just to avoid the surprise sensation of touch on the body. Prior to an internal exam, whether it's a vaginal exam, rectal exam, you can tell the patient, give them a heads up. Hey, you're going to feel my hand on the thigh or on the buttocks. Prepare patients for other sensations, like this vaccine will be a quick pinch. The speculum may feel cold. And finally, be efficient. Here are some examples of efficiency. You can inform the patient how long a particular exam or procedure or any intervention will take beforehand. You can avoid keeping the blood pressure cuff inflated for too long, as that also can resemble a restraint. Please take breaks of any exam where the mouth is held in an open, fixed position, because prior forced oral sex is a really important and under-recognized cause for avoidance of routine dental care. And ask the patient to show you a genital lesion rather than taking the time to find it yourself. It can take too long, it can be uncomfortable for you and them, and can be misinterpreted. And we're transitioning now to after the exam. Definitely you can thank the patient for helping you to conduct a thorough exam, and you can discuss results once they're back in their regular clothes and seated in a comfortable chair of their choice. And finally ask, what questions do you have? Rather than, do you have any questions? Where people maybe feel pressured to say, no, doc, or no, nurse, I don't have any questions. You can pause and look at them in the eye and ask, what questions do you have? So this is a summary slide that shows a depiction of what we just went through. This is a framework for a trauma-informed physical exam, how to speak and behave before, during, and after in a way that creates a sense of safety, collaboration, and empowerment. So in summary, trauma is highly, highly prevalent amongst our patients, our staff, trainees, and ourselves. Trauma can absolutely impact patients' experience with their clinical care, including your medical interview and your physical exams. We do have a responsibility towards our patients and toward one another to foster an environment of safety and respect, regardless of trauma history. These are universal precautions that we can apply, just like hand washing. And so those are my references for anybody who's interested in additional resources. I like looking at acesaware.org, PACES Connection. PACES stands for Positive and Adverse Childhood Experiences. It's a forum for advocacy, fellowship, connection, and trainings. The Roadmap for Resilience is the California U.S. Surgeon General's report on ACEs. And finally, at the bottom, there's this change package that was published for Kaiser Permanente in the United States with specific strategies for how to make their primary care clinics trauma informed. So with that, I will close. If there are a couple minutes available for questions, comments, and or suggestions, I am gladly happy to take them. This is my website. You're welcome to contact me through this site in order to continue the conversation. Thank you so much.
Are we able to ask questions now?
Thank you very much, Saida, for your presentation. We have a question on chat. Do you have a procedure for TUS patients with hearing loss?
Yes, thank you so much for asking that. I was able to address that question during my talk. Thank you, Richard.
Okay. Okay, so we don't have other questions. Julie,
there is a comment in the chat that I would be happy to take.
Hi, Dr. Getz, Julie Getz from Phoenix, Arizona. I'm at U of A, and my mom actually works at the VA hospital here in Phoenix.
Oh,
so
wow.
she seems to use a lot of your approaches. She's the first point of care for when the patients come in, usually when they're living on the street, they've been off their medications, especially their mental health medications, and most importantly, their pain medications. So they're turning to street drugs in order to address that. So I guess I would, I wonder if there's anything additional that would be helpful for her. You know, she is in a room without any chairs, any decorations, anything, because there are a lot of health hazards because, as I said, they're off their a lot of them are off their medication and they're on other drugs. So she does as much as I know she does as much as she can to make them feel comfortable, make them feel safe. There's often times where she said, I just had to leave the patient. I couldn't do the physical to the next day because they just weren't comfortable. So I'm going to actually try to share some of the information here, which I'm sure she's already learned, and I know she does her best to address. But when it comes to mental health specifically, is there anything else that you would suggest?
Of course.
Coming to,
Of course. Thank you, Dr. Getz, for that.
I'm sorry, I have a bit of a cold, so
it's all good. I hope you get better soon. Yeah, it sounds
Thank
like
you.
your mother is doing remarkable work. That's very impactful and meaningful work, and it can be extremely challenging for her as well. So I encourage her to explore her own boundaries and well-being and self-care and thinking about the impacts of vicarious trauma on all of us in healthcare, particularly those who work in mental health with individuals who have a housing instability, et cetera. So I think one of the things that comes to mind for me is this concept called the window of tolerance. And it's an important concept in psychology and traumatology. We all aim to stay in this window of optimal arousal where we can think and act clearly at home or at work. But sometimes anything that is sensory similar to a previous painful lived experience can activate the brain to go into a threat response, and we can potentially go out of that window into hyperarousal, where we're very agitated, we are tense, we are on edge, we're ready to fight or flee. We could also go down out of that window into hypoarousal, where we're withdrawn, we're detached, we're totally checked out, and the patient's just silent and in another world, maybe dissociated. So it's helpful to, before entering an exam room, check in with yourself. Am I in my window of tolerance right now? And then when you enter a room, if the patient's agitated, rather than labeling them as a bad person, this is a nasty patient. This is a, you name it, bad, nasty term. Recognize that their behavior is a manifestation of internal stress and usually a reflection of serious prior and or current pain. And if we acknowledge that, we can proceed with empathy. And usually it's about building an initial therapeutic rapport within the first 60 seconds. You sit, you look, you listen, you communicate warmth with your physical demeanor, as well as with your tone of voice, your facial expression, and the content of the words that you use. We avoid language that is blaming or shaming, like homeless alcoholic. And we instead use terms that acknowledge and aim to address social and structural injustices. And it's okay. We have the benefit, if we're not working in an emergency room and if the patient's not coding in front of us, we have the benefit of time. There's time. You don't have to do the physical exam that second, right? So you can just listen and nod and validate and say, wow, that sounds really difficult. I can understand how you would be feeling this way. I think anybody in your shoes would be having a hard time. It sounds like you're just doing the best you can, and my only role is to support you.
She's
Now,
way more patience than I think I would have in that situation. She is phenomenal. She says, okay, I will be back. And if it takes till tomorrow, we'll come back tomorrow. She's 73 years old, little tiny white lady, with her walker, and she probably gonna do it for the, until she ends her days. She does love it. She does do something where she starts off with, if they, if they're not a military spouse and they were in the military, hello, sergeant, whatever they are, and just sort of sets them in the mind frame, like they kind of perk up a little bit. And so I know that's one thing that she does try to do, but sometimes, the patients, like I said, they're coming in, they've probably been brought in by ambulance, or it's a trauma in itself. They're brought in by ambulance, or they're brought in by the police department. They are not, there's other health needs that need to be addressed, but if it's nothing emergent at the moment, she will just let them sit and come back later. So I will share some of this with her as well.
Very healing centered and trauma informed. That's brilliant.
Yeah. So thank you.
Thanks so much. Of course.
Thank you very much. So this is all for today. So see you tomorrow. Have a good evening.
Thanks so much,
Bye.
everyone.
Thanks, everyone.